Yes.
Afternoon, David.
Yes, good afternoon.
Yep.
Chairman and everybody.
Sound's working good.
Hello, David.
Good afternoon.
Okay, welcome everybody to today's meeting of the Health Overview and Scrutiny Committee, 9th of September 2020. I'm Ewan Walters, Senior Democratic Services Officer, and I'm starting this meeting off because it's the first HOSC meeting since the annual council meeting, and it's being held online due to the current situation. The meeting is being broadcast live to the public on YouTube, and for those not able to watch the footage live, the webcast will be available for viewing after the meeting. And can I ask all officers and members to mute their microphone until they wish or are invited to speak. And then when you're speaking, please turn your video on so the people watching on YouTube know who's speaking. Okay. So I'm now going to go around and ask the committee members to introduce themselves. I understand there are no substitutes today. Mr. Bill, are you online and can you hear me?
I can, yes, and I'm here.
Excellent.
Good afternoon, everybody.
Mr. Coxon, are you on the line? Mr. Coxon? No? Dr. Feltham, are you there?
I am, yes, and I'm the county councillor for the Gartree division. Mr. Coxon was on our little briefing we had earlier, so he's around, but just trying to get through.
Okay, we'll perhaps try him again in a second.
Yeah.
Mrs. Hack, are you there?
I am, yes.
Okay. Dr. Hill?
Not seen that.
Dr. Sarah Hill, are you on the line? Okay. Mr. Morgan, are you there?
I'm here and I can hear you and see you.
Thank you. Mr. Orson?
Here.
Thank you. Mrs. Rosita Page?
I can see and hear you. Hello, everybody.
Thank you. Mr. Ted Parton?
Good afternoon, County Councillor, Loughborough South Division.
Yeah.
Thank you. I'll just try. Mr. Coxon, are you on the line?
Not yet.
No, okay. And Dr. Hill, are you on the line now?
No.
Okay. Well, the committee is Cohorts, so we can continue. We also have the Cabinet Lead Member for Health, Wellbeing and Sport on the line, Mr. Lee Brecken. Mr. Brecken, can you hear me?
Yes, hear and see you. Good afternoon, all.
Excellent, thank you. Okay, we'll move on to the agenda then. The first item is appointment of chairman, and Dr. Feltham was nominated as chairman-elect at the County Council meeting on the 8th of July. Can I have a proposer and seconder that Dr. Feltham be appointed chair, please? Would anybody like to propose that?
I would like to propose, please.
Okay, and the seconder?
Oh, Mr. Bill is waving.
Mr. Bill waving, and Rosita was about to speak. Okay, so everybody in favour of Dr. Feltham being appointed chair? Yeah, okay. Dr. Feltham, you are now appointed chair for the 2020-2021 year, and I will hand over to you for the rest of the meeting.
Thank you very much, Ewan. Thank you. So item 2 is election of deputy chairman. Do we have any nominations for deputy chairman, please?
Chair, I would like to nominate Mr. Ted Parton as vice chair.
And I'm happy to second that.
Thank you very much. Any other nominations? No, thank you. Everybody happy? Everyone in favour? All nod? Very good. Thank you for nodding.
Thank you very much.
Ted,
Thank you.
that's it. You're now deputy chairman, Ted. I'll go away now. Run the meeting. No, hold on. So last meeting we had was on the 3rd of June. I propose that the minutes of the meeting held on the 3rd of June were taken and read, confirmed and signed. Agreed? Agreed. Thank you very much. John Coxon's just joining, I see. Question time. I've not received any questions from the public. Questions asked by members under Standing Order 7.3 and 7.5. I have received a question from Councillor Max Hunt, and there's been a response which everyone's now received that's on the committee, and a copy of circulated for you all. Mr. Hunt, I understand, is not present and doesn't wish to ask a supplementary question. So all we have is the document and the answers, the questions and the answers on the table, and we'll take them at that and leave them on the table. So it's up to him really to take it any further. Thank you very much. Item 6, there are no urgent items that I've decided to move up or down the agenda. So it's as the agenda stands. Item 7 is declarations of interest. Do any members have any interest they wish to declare? No one shouting. Thank you very much. And number 8 is declarations of party whip. Does anybody have any declarations of party whip to declare? No. Again, no one's rushing around. Presentation of petitions under Standing Order 36. I've not received any petitions. In which case, we now move on to the main item, first main item on the today, which is the consultation on the Nhs Rehabilitation Center. And I see Ewan is loading up the presentation. To present this item and explain what the consultation is about, we have Hazel Buchanan, I understand, Associate Director of Strategic Programmes, Nottinghamshire CCG, and Miriam Duffy, who is the Programme Director, National Rehabilitation Centre. You've also received this week in the pack comments from the Leicestershire and Rutland CCGs relating to this item. So really, it's over to you, Hazel and Miriam, to take us through.
Thank you. So I'm going to, my name's Hazel, and I'm going to do the presentation. So Ewan's handed me control, so I think it's the first time I've done it, but I'm sure it'll work fine. So we're here to talk to you about the Nhs Rehab Center at Stanford Hall, where we're currently carrying out a consultation. The Nhs Rehab Center is part of a National Rehab Center program, and it's on a site called the Stanford Hall Rehabilitation Estate. On that estate, there was a military rehab facility that opened in 2018, and this was on the, as I mentioned, this was on the estate, which is owned by the Black Stork charity. The Black Stork charity donated land for the NHS, and it was always their vision from the start to have the military facility alongside an NHS facility. Planning permission was received for the NHS rehab facility, and that includes the clinical facility, which is what we're calling the Nhs Rehab Center, a national research and innovation hub, and a training and education centre. So these will, in effect, be all in a single building. But what we have received is a funding allocation for the NHS element. The location, you can see just quickly from this map, is in between Nottingham and Leicester, and close to Loughborough. In the consultation, there is a focus on the location, and that's really because it's quite remote, and so it's the impact of the travel for visitors. As it's an inpatient facility, the location won't impact on the access for patients themselves. So the Nhs Rehab Center is what we call 2B rehab facility. So there's three levels, and the level 1, 2, and 3. And as I mentioned, this is 2B. What we have got in the areas in the East Midlands is level 1, 2A, and 2B. Level 1 and 2A, don't want to complicate things, but I just think it helps to set this context. Level 1 and 2A are commissioned by NHS England, and as a result, they're regional centres, so covering the East Midlands. So at the moment in Leicester, there's a level 1 unit with 9 beds and a level 2A unit with 16 beds, but no 2B unit. And in Nottinghamshire, as an example, there's a 2B unit. So the Nhs Rehab Centre is a 2B unit, but what we're doing as part of this whole proposal is how do we ensure that the pathway and the journey through the different levels is accessible for patients based on an East Midlands, based on the East Midlands. So the patient cohorts are predominantly neurological patients, and those facilities I just outlined are neuro facilities, MSK patients, and in particular complex fractures post-surgery. There is the option for severely deconditioned patients to access the centre and traumatic amputees. These are the majority of the patients that will be accessing the centre, but as we've seen through COVID, there may be other opportunities or cohorts to consider, but these will be built on the pathways around neuro and MSK. The clinical model is referral through a single point. It's really providing intensive rehab with a multidisciplinary team approach. And the estate really facilitates this, and that is where there is the opportunity. And also there's access to some of the facilities on the military site, which we wouldn't normally have access to through the NHS. There'll be new roles through the clinical model, and in particular, there'll be clinical case managers, which will follow individuals through from referral all the way through to discharge. And as part of this, there's what we call the trusted assessor model, and that's where patients can be assessed in different trusts, and that assessment will be used for their care in the rehab centre, and equally the rehab centre. When patients are discharged, the package of care will be taken on board through with community settings or wherever the patient is transferred to. So we are in the middle of the consultation. This has followed an extensive engagement process, which included 2 phases. Through these phases, we had focus groups and surveys. Those informed the pre-consultation business case and also how we take forward the consultation. There has obviously been a gap between phase 2 and phase 3, and this is as a result of COVID and having to put the consultation on hold. But what we have done through the consultation, so we're running an 8 weeks consultation, which was slightly longer than we were originally planning, which was 6 weeks. It is all virtual, so it's virtual events. We've been holding virtual events and focus groups, and there's also a survey, and there's different ways to complete the survey, which includes over the phone. The consultation is also being supported by Health Watch, and they've been carrying out targeted engagement with vulnerable groups, and did start some of this work before COVID impacted on us. So that is a bit of a whistle-stop tour to give you the main points and to allow us time to have some discussion for this agenda item.
Thanks, Hazel. Have you seen the response that we've been given by the CCGs?
Yeah.
Yeah. Any comment?
Well, I think yeah. So that fits back to the slide around the different levels. So I guess there's 2 points. So one is that the home first, and absolutely we all want to support anything that's home first, and the opportunity to keep people out of the hospitals. But this is part of a patient's journey, so it would support them in home first. It also depends on the complexity of the individuals. So when we're looking at those different levels, this is 2B. So it may be an individual has been in level 1 and they step down into 2B. And it's providing the right care at the right time. So there's some people which we're considering now for the decision-making business case. So where would it be appropriate that they go home first, but potentially come back into the rehab centre where they may need that intensive rehabilitation? But the pathway is around, you know, how do we support people to live independently at home, provide intensive rehab so they do get out of an acute setting sooner, and are able to function more effectively when they're at home.
Thanks very much. Ted, you've got a question. Yeah,
Thank you very much. I'm looking at page 3, which is 17 on our agenda pack, but in terms of your presentation, page 3, please will have some clarification regarding patients referred there would have access to some of the military rehabilitation facilities, but would be treated by NHS staff in a separate building. As somebody, as probably anybody knows, if you try to get access onto a military site, certainly in the last 3 or 4 years with terrorist incidents, you have to go through at least 2 sets of security barriers. How would this actually work on an actual infrastructure setting? Are we talking about moving medical equipment back and forth between buildings or personnel? I want to just know how that would work.
Yeah, so if I put Miriam, would you like to answer that?
Yes, that's absolutely fine. Hello, everyone. I'm Miriam Duffy. So the programme from the outset has always been to have 2 separate units for inpatients on the Stanford Rehabilitation estate. The Defence programme was fundraised to the tune of £300 million to build their facilities, and they do have state-of-the-art facilities that we just frankly wouldn't be able to afford to provide through the NHS route. So the agreement has always been that they would be able to be shared by NHS patients, which is a fantastic opportunity for us. Now, the agreements around access are really important to understand. So the military patients will be always treated by military personnel and dealt with separately. NHS patients will always be treated by NHS clinicians and dealt with separately. So we're not treating the 2 groups of patients together, but we will access those facilities as and when we need them for our NHS patients and take those staff with us. So in terms of security, I mean, it is a secure site, but we will be part of that overall staff group. So we will have swipe access to that facility just like any of the military staff would do. So that has all been agreed. We're currently at the stage where we're looking at timetables and when those points could be available to us. But certainly we wouldn't look to duplicate any of the resources that we do have to share. So we wouldn't be transporting medical equipment, but we will be taking patients over there. Now the distance is very small, so it's only 400 metres, and easily we could do that with a patient across a hospital site, either in Leicester or Nottingham now. So it's not insurmountable distance-wise.
Thanks, Miriam.
I did have one more question.
Go
on. And this is going to sound facetious, but often when people use the term state-of-the-art, it can sometimes rather sort of tongue-in-cheek be described as simply new. So when we talk in the report about state-of-the-art equipment, are we talking here about equipment that previously has not been used or to such a level, or are we talking about equipment that the NHS has, but you will have more of it?
So really good question. Do you want me to pick that up, Hazel?
Yeah, sure.
The computer-aided rehabilitation environment, the CAREN, that's on that slide, is complete state-of-the-art. There are only 6 in the world, of which this is one. So this is very new. It's incredibly impressive. It's a huge dome with virtual reality dome with a balance plate in the centre, which is very sensitive, and a harness. So it's used for a number of things. So for gait re-education, for vestibular rehab, for prosthetic adjustment. So it's really proved to be very useful. And because it's so new, what we're learning in our collaboration with defence colleagues is that they're learning all the time the benefits of having that piece of equipment. So they're learning very, very quickly. The other key piece of equipment to draw out is the gait laboratory. So we don't have access to a gait laboratory at all at the moment through any of our acute hospitals. And what that does is give us images as a patient moves, so we can be very specific around our rehabilitation in terms of which muscle groups we need to focus on, what the areas of talk are, and we can really get to a level of detail that we just cannot do at the moment through scientific methods. So that will feed into the multidisciplinary team a level of information that they frankly just don't have at the moment. So they would be the two pieces of equipment to identify to you that are really state of the art. The two other areas that we have access to, the hydrotherapy pool and the prosthetics laboratory, they're not state of the art, but we don't have access to them at the moment. So they would be very new for us. So, hydrotherapy pools have been around for ages, haven't they? But none of our acute hospitals, again, have access to that piece of equipment at the moment. So very valuable from a rehab point of view.
Thank you very much. Is that okay? Yeah, thanks very much. Sarah, you've got your hand up.
Thank you, Chair, and apologies for my late arrival. My county council IT decided it wouldn't pay for me for a bit. I think it's a wonderful thing and extremely shiny and lovely, particularly the type to the military. But I do wonder about how many customers you'll get, for want of better expression, from across our area and elsewhere. And I also have concerns long term. I'm going to put this unsubtly. The military eventually will stop operations where, unfortunately, their servicemen are going to get badly injured and need the facility that you're allied to. And, I can see demand for that side reducing, or the military decide, it can't spend any more money on it and they'll shut it because, don't say it won't happen because it happens. We've seen examples of that locally before. So I'm just concerned really about the long-term viability of it. Because it's spending a lot of money on a very nice building, but if in 10 years somebody comes along and says, oh, well, we haven't got the patient, we'll shut it, it'd be disappointing, to say the least.
Yes, thank you. Again, happy to take that one. So there are two different points there, I think. The first one, in terms of Nhs Demand, actually our region is woefully short of inpatient rehabilitation capacity. We only provide 33% of the recommendation against the British Society of Rehab Medicine standards. So that results in long waiting lists for our rehabilitation beds and a large number of patients who never access inpatient rehab. And as Hazel said at the beginning, to the response to the CCG input, actually this supports Home First tremendously, because we've taken length of stay that patients currently have in acute beds, transferred that into a rehab spell so that they will hopefully spend a shorter time overall in a hospital bed, so to speak, so that they can go home with better outcomes. So the demand is absolutely there, and it's clear in the PCBC that that's been modelled quite accurately, I think it's fair to say, and arguably will outstrip the capacity that we've got actually to provide that. The second point is a really interesting one. So until I was involved in this project, I had exactly the same perception of the type of patient that went through that military facility, but actually 85% of their activity is generated on exercise or just in normal life events. So they are similar things that we would experience as general members of the public, so road traffic accidents, sporting injuries, etc. So actually the surge capacity that they have, if you like, for those active periods is surge capacity, and their day-to-day isn't that type of injury. That's not to say that they don't always have very complex patients in that facility, they do, but they're from a very similar origin to the patients that we would be seeing as well, those normal life events rather than periods of intense activity.
I think it's also important just to mention that Miriam has a really close working relationship with the military through this, and alongside the Nhs Rehab Center, which we're obviously consulting on, is the research side of things. they're absolutely committed to joining up on research and looking at what we could do or how we can really extend the research by using the NHS services and NHS patients alongside the military. So there's huge opportunities there that would extend the sustainability of the whole rehab estate.
Thank you very much. I've got no more questions for anybody. So thank you very much indeed for a presentation. Obviously, we're part of the consultation now. hope the questions have been useful. And say thank you very much for joining us today. Thank you very much.
Thank you.
Thank you. Goodbye.
Bye.
Goodbye. Item 11, this next item relates to the paper Community Services in Ashby de la Zouch. It's really an information paper, but I felt it was important that we had the opportunity to perhaps discuss it, as we've had comments about Ashby services for several years now. For this item, we've got Tamsin. I've seen her. Yep, there she is. Assistant Director of Urgent and Emergency Care, LLR CCGs, and Ian Potter, Head of Transformation for the LLR CCGs. So I'll let you go ahead, Tamsin.
Thank you and good afternoon. Hi. I was reflecting on the last time we discussed this topic, and it feels like a lifetime ago, being pre the COVID pandemic, back in January, I think it was. The paper is a relatively brief one, and I'll just highlight the key things in it. It's an update on the work we've been doing to develop primary and community care services across Leicestershire, but with a specific focus on what is available to the community in Ashby, since that has been of interest. Okay, so I think when I spoke to you last, we had only recently mobilised a change to how Leicestershire Partnership Trust community services were working to take them more towards an integrated care model that supported our landscape of emerging primary care networks, but also could better integrate with social care services. And that involved the creation of 6 community hubs for community services across Leicestershire. That mobilisation has gone really well, we think, particularly given the time that we did it in was over winter, and has been sustained through the experience of COVID. And some of the benefits are highlighted in the paper, including the fact that we've got a greater critical mass of teams now who are more able to provide continuity of care and meet unplanned care needs, and that has been a key benefit. And we've seen since the mobilisation in December, in the 3 months pre-COVID, distorted all of our data and made it hard to track trends, a 5% reductions in admissions for frailty conditions and a 9% reduction in readmissions of patients, which were 2 of the key things that we were hoping to achieve through that service change. So that was really pleasing to see. We're also making good progress towards the national expectation that we provided 2-hour crisis response service in the community and can commence reablement within 2 days. And again, that's working really closely with the local authority teams in county and in city and Rutland. So that continues to be embedded, that model, but at the same time we are in active planning with Leicestershire County Council to co-locate their crisis response and reablement services into those 6 community hubs. And there is a lot of evidence that co-location of teams really does provide great benefits for residents and for staff themselves in terms of them being able to deliver much better integrated care. So we hope that will be achieved by October, although the COVID pandemic has created some challenges around that. The other thing that we have been able to do through being a national accelerator site for Ageing Well has been to provide some funding to increase crisis response capacity within the local authority to support those community hub teams. Recruitment's been a challenge, but there's a real commitment to increase that capacity aligned to the hubs as well, which is good. So Ashby specifically is served by the Colville hub, but there are district nursing clinics closer to Ashby than that. And so not all staff work from Colville all of the time, and obviously they are largely working in people's homes as well. So turning to the delivery of additional services within primary care, I think perhaps this is an area of development we didn't focus on enough when we spoke in January. So as well as services in community hospitals as such, it's a key part of our approach to developing services, that we are developing services delivered through primary care premises and sometimes by primary care staff, using the mechanism of primary care networks as sort of the geography for that. Now, Ashby is part of Northwest Leicestershire PCM, but within that there are 3 smaller local neighbourhoods, and Ashby is one of those. So the paper lists the additional services that are available to patients in Ashby, delivered either by the PCN or through practices located within Ashby. And I won't list those, you can read them. And finally, there was a request to update on the use of Section 106 funding in Ashby, and I'm conscious there is a longer paper about the primary care estate strategy on your agenda today, and that Tim Sachs is here to talk about that. But the report details an investment of £720,000 of Section 106 funding to support the development of a Skeevy house in Ashby, to develop more clinical space. And some of that clinical space is to house the new staff groups and services that are referred to in the previous section in the report. So I will stop there, if that's okay, and answer any questions.
Thank you very much. First question, I think, is from John Coxon. John, you'll need to turn your audio off. That's it.
Yeah. Okay, thank you. It's really a question that's been raised by the Ashby Civic Society. They're concerned regarding the £720,000 Section 106. They're asking who will actually own that £720,000 worth of investment.
Yeah, so
because obviously somebody will own it at the end of the day, and they're concerned that should the building be sold or other things happen to it, who will actually end up with the loot, I suppose.
Well, no, that's absolutely understandable question, and I think we can give it a clear answer to that. So I'm going to bring in my colleague Tim Sachs, if that's okay, to answer that question.
Thank you.
Go, Tim.
Thank you. Good afternoon, everyone. My name is Tim Sachs. I work for the CCGs, leading on estate planning, particularly primary care estate at this current time. Now, in answer to your question, when Section 106 or community interest levy funding comes through for primary care estate, the way it's treated as a capital grant by the NHS. So what then happens is that funding is then used for the development of a premises, in this case in Ashby. What will then happen is that premises is developed to provide the additional space that's required. And the way that the NHS treats that is that it has significant impact on us, in that the way the NHS works for primary care estate is that we have to fund what's called notional rent. So a district valuer will look at any building, and we will then have to pay per square metre according to the state of the building, which can run in some cases for large practices to multiples of hundreds of thousands of pounds per year. Now, when Section 106 funding is used, we can abate that rent for 15 years. Now, that can either be abated entirely, as in no notional rent will be due on that, but more normally, notional rent is reduced by 66%. So if it was £100,000 we needed to pay per year, that would reduce down to £33,000. Now, the whole point of that 15-year abatement is actually, one, to reduce the amount of revenue that the NHS has to spend, because as CCGs we have no capital. But on the other side, it is to make sure that actually there is value for money in relation to the fact that the money, going back to your point, is actually given to the owner of the property. Well, the money itself isn't, but the value of the premises once it has been done. So the CCG holds the money, it pays for the development, but the ownership remains with whoever owns that building, whether that be the partners or a third party. So in answer to your question, the fact is the building could be sold in the future, but it would have to be used for healthcare. It couldn't be sold and then not used for healthcare, so it could change providers. However, it will need to be used for healthcare, but the ownership of that building is entirely with the current owner, and the money has been made back through reduced notional rent. I hope that answers the question.
Yeah, I think it does actually. I don't suppose you could email me that answer, could you? No, is that possible, Kevin? Or?
I'm sure we can find some way of getting some kind of if not.
Yeah.
Yeah.
Yes, that'd be helpful if you would.
Clearly, the whole meeting is now being broadcast, so will be available on YouTube anyway.
Yes,
so
I will ask them to obviously view YouTube.
Yeah, that's the
Thanks very much.
Thanks, Tim. Very good. Rosita, I think you're the next one.
Thank you very much. And there will be a lot of questions because I'm a newbie. On this report, 2 questions, well, 3 actually. Could you please identify the 6 community hubs for me? Because I don't know where they are. Under point 9, it says, looking at the model of care delivered in community hospitals, does that include Lutterworth? And then my 3rd point, it's rather in response or of the reply Mr. Sachs just given. Now, as far as I understand, Section 106 monies legally have to be utilised to demonstrate and ensure that you have got tangible, sustainable outcomes that a new development will bring. So, i.e., what you've got to demonstrate, it is how you meet the patient needs of the future development, the increase. So, and it is a legal requirement. So I'm not sure how the revenue that is spent on a building can be used to meet this need to provide extra health infrastructure. So can you explain that to me? Because, you know, how do the new increased population get benefit if a building is being done up? You know, so if you can explain that. Thank you.
Who wants to take that?
Yes, so thanks. So the 6 community hubs are, and I will need probably to come back with you for their exact locations, but they cover Colville and that area of northwest Leicestershire. I've got Rachel Bills, I can see, so she probably is much more au fait with the names. There is one based at Melton that covers Melton, Syston and Rutland. There is one based that covers Hinckley and Bosworth. There's one that covers Loughborough and Charnwood, and there is one that covers the south of the county, including Market, Harborough and Lutterworth. I think I'm right in saying. Now, the actual addresses of where each of those hubs are, I can provide details with you, but that's broadly kind of the hub geography coverage. Rachel, come in, please, if I have mangled that at all.
No, that's absolutely right, Tamsin. And Rosita, if it would help, we can supply a map after the meeting that shows you where the we can send that through to you, and no problem.
That'd be useful, yeah.
And then your second question really was around, I think, how capital expenditure in premises could be a benefit to patients, if I understood you right. Mm-hmm. Yeah, OK, so I think Tim will probably cover this as well when he talks about primary care strategy. But in essence, in order to deliver care and to deliver high quality care to people close to their home, we need consulting room and treatment rooms that are fit for practice. Now, primary care premises historically have not been that fit for purpose in terms of spaciousness or the way the rooms are configured, particularly if we want to do minor procedures in primary care, for instance. They need to meet certain clinical specifications. Also, as we try to expand the workforce in primary care to meet the growing demand for primary care consultations, historically a lot of buildings just have not got the consulting space to accommodate the staff, even if we can make the staff available. So the lack of consulting space can mean long waits for people to be seen. So we need appropriately sized and equipped physical premises in primary and community care to deliver modern healthcare and meet our ambition for care closer to home. Otherwise, we're expecting people to travel a very long way, potentially to a hospital site, to get something that could be delivered in their local area. So I hope you can see there what the benefit is to people directly through that investment.
So I assume that if the premises are developed and enhanced, even at the benefit of the owner, the infrastructure, i.e. the equipment and the staff, then automatically follows to provide the outcome. Is that how I understand it? Yes.
So it's not necessary that the investment of capital will bring with it the investment of the revenue and workforce. But I think in this case, there is a conjunction of those two things happening. So as you can see from the report, we are expanding the primary care workforce, and the PCNs are working together with other providers to want to deliver more at a very local area. So we've recruited social prescribers, for instance, we've recruited care coordinators, we're recruiting first contact physiotherapists. As we expand that workforce in Ashby area, or in fact any other area, they need somewhere to work from. Those roles are funded, but they're funded through a different funding mechanism to Section 106. So, and I think often the CCGs historically haven't asked for the investment of 106 monies because we couldn't provide the revenue alongside that. So you could build a lovely new surgery, but actually there weren't any GPs to put in it. In this instance, in Ashby, both things are in place, and that's made it viable to put that extension together.
Number 9, the model of care being delivered in community hospitals across Leicestershire, Leicester and Rutland. Does that include Lutterworth?
It will include Fielding, Palmer and Lutterworth, yes.
Thank you.
Thank you very much.
So, no, could I have an update of that at one point, what it actually includes, so I can share that? Thank you very much. Thank you.
Yes, absolutely.
Yeah.
Would you like that to come as part of your future agenda, or would you like that more as a briefing?
I think information briefing sounds sensible. Yeah.
Yeah, fine. No problem. We can arrange for that.
Thank you.
Ted, you had your hand up. Is it on this topic, or is it left over from the last one?
My apologies. Yes, I must remember to lower the hand.
Okay. In that case, Sarah.
Thank you, Jen. I'll lower the hand now. Just a bit of a follow-up on what was just said. In here there is a handy, I've lost it now, and true efficient fanner. The community care service development in Ashby, and it says all those things. I'd like to see that. If you're going to do a briefing document, can you give us that sort of detail for all the primary care network hubs, so everybody knows what's going on in their local area? It'd be just really handy to know what's happening all over
across the patch.
Yeah.
I absolutely don't see why not. It won't be myself that has that information, but I can arrange for that to be done, certainly, no problem.
Yeah, and I think if Rachel's going to give us the map, we might as well know what's going on in each one. It'd be very helpful. Yeah. Thank you, Tamsin.
Sure.
Yeah. Anyone else? No, I've got no other hands, right? So I think, thank you, Tamsin, and thank you, Rachel, taking us through that. It's now back to Tim again, who is going to talk to us about the primary care estate strategy. Gosh, that's a mouthful.
Thank you very much, Chair. Very much appreciated. So let me just run through in brief. I know that you've had the paper. So what is the point of what we're doing, and what's the outcome that we're seeking? Excuse me. So in brief, the whole point is we're undertaking a 3-phase process to pull together a primary care estate strategy. The aim of this is to have something that involves all partners within Leicester, Leicestershire and Rutland, so that we have an integrated approach to building development to ensure that we improve the health outcomes of the population. Just a little bit of background. Across Leicestershire and Rutland, we've got 133 GP practices and 197 premises which are delivering some form of healthcare or other. That ranges from village halls where people can pick up prescriptions in some areas to surgeries with nearly 40,000 patients registered there. So there is a vast difference between that, and also a vast difference from the fact that some of them are mid-terraces and others are very new purpose-built premises. So the key point here is we need to make sure that we've got appropriate, modern, fit-for-purpose premises for all the patients of Leicester, Leicestershire and Rutland. Now, to undertake this piece of work, there are a number of things that we've been doing, and phase one has involved a chartered surveyor going to every single one of those buildings and doing a six-facet survey. For those who don't fully understand what a six-facet survey is, it takes into consideration a number of areas. Firstly, the size of the premises in relation to the number of patients who are registered there, the quality, health and safety, functionality, and also any backlog maintenance that would be involved with that, and also space utilization. So it gives us a plethora of data from which to then build. However, it's not enough in itself. There is significantly additional information that we've been looking at. So in the first phase, what we've also done is look at all of the local development plans from the planning authorities to look at housing development up to 2031 or 2036, according to when the plans have been written to, and also taking into consideration future planning from there as best we can up to 2050. So when pulling that together, what that does is it's given us a real understanding so far of where we have particular issues with practices and also where the growth is likely to be. So we will need to focus our attentions. So the second part is we are analysing this, and we're pulling it together both on a practice basis and also at a primary care network basis. Although actually the chapters we've done on a district council and unitary authority boundary, because actually then we want to build that into our strategy for place-based delivery to ensure that what we do have is plans that people recognise, and particularly from your councillors basis and your constituent basis, people can recognise the geography, because a primary care network doesn't necessarily make sense geographically for where people live in that part. So the second part is we're really pulling that together and then looking at putting some other data on top of it, which looks at a number of key areas. So we will map this information out and also take into consideration some socioeconomic elements to it as well. So particularly where there are high levels of multimorbidity, where healthy life expectancy is reduced, and also population growth as well as housing growth. So we're able to map that according to where a state makes a difference to patients, and where having an appropriate estate will add value when it comes down to the need that they have. So, for example, a patient with lots of long-term conditions is likely to need more care than a patient that doesn't have lots of long-term conditions, and therefore would need more appointments, ergo more space. So really working through it that way. The aim really afterwards is when we consider the next option, so the next phase would be once we've pulled that together and understood exactly where there is, each of the areas, so whether it's district council area, unitary authority, or on a primary care network, we will then look at doing the actual feasibility studies of what do we do next. Because it's all well and good to understand that there may be lots of people moving in, but we have to understand when they're moving in, how we would then be able to adapt the existing premises. Do we need new premises? Or in the case of Leicester City, what are the opportunities if there are premises which are in dire need? So we'll look at maximising the existing space that we have. We'll also look at other solutions which may not involve building new buildings, but also whether they're working with our partners, yourselves in the council, also with our colleagues at Leicester Partnership Trust, to see if there are other buildings that would be able to support delivery of care. If we just return it back to the conversation that we just had from Tamsin, the paper in relation to primary care networks, to put it into perspective, by 2023-24, for a population of 50,000 patients, the government will have funded an additional 13 to 15 staff, clinical staff or staff to support. Now they have to live somewhere. Now, I know we have lots of new ways of working and we're going to have to adapt, but that's a lot of people which are going to require space. So we have to look at the new ways of working as well as the additional staff to make sure that we map this accordingly to ensure that that patients are getting the improved healthcare through the additional roles that are coming forward. The next stage will then be looking at the financial part of it. So as we previously discussed before, we need to make sure that we have a very clear process in relation to Section 106 and SIL funding, because at the moment, each of the 7 district councils do it slightly differently, and the 3 CCGs have done it slightly differently. So one of the parts of this work will make sure that we have a singular process that we've agreed with all councils to make sure that we have it much more streamlined so we can maximise the opportunity for development. And then over and above that, there's obviously, in case of where there are opportunity for NHS capital, which is very rare. And we've had some capital over the last 3 or 4 years, but it is quite rare that capital comes into place for a state. Those of you will recall papers previously about the Estates Technology and Transformation Fund, which has helped support the development and extension of a number of premises across Leicestershire. And then the final part of that is really running through and sharing this in relation to each of the individual given areas on what sort of development is possible, what is feasible and what is financially doable, so that we can have a longer term plan which is going to provide us with a solution so we have the best possible estate we can to deliver healthcare. I will stop there, Chair. Thank you very much and very happy to take any questions.
Thank you very much, Tim. Very, very helpful. David Bill.
Thank you. Thank you, Chairman. And thank you, Tim. I think this topic is one in which most of us who are active councillors are involved with, possibly more than any other topic, because we've always said, and we've all said this in our own words, when faced with the growth that we're expected to take, that there should not be growth without infrastructure. And we always talk about roads, of course, but second to that, we talk about health facilities, because the people out there saying, you're agreeing to all this development, where are the schools, where are the roads, and above everything else, where is the surgery? Where are the health? The current surgeries can't cope because when things are running normally, you can't get in to see the doctor for 6 weeks because every surgery now has such a growth of patients. I know it's changed. It's been changed over the last 6 months, but that is when things are actually operating normally. That is the great challenge for us. We're being asked all the time, where is the infrastructure? And it all comes down to the interface between the planning system, with which we're all only too well familiar, and the CCGs. And we try to find out what's going on as councillors, and the only information we ever get from our planning departments is a discussion about 106 monies. We're not asked to put an input into where we think surgery should be, and all the rest of it, and how big the surgery should be. We're only asked to note that 106 monies eventually leaves the district council officers and goes into the CCG. Whether it all goes in and whether all that cash actually leaves the district planning officers and gets to the CG, I don't know, but that's how we understand it operates. And then we lose, as councillors, then we lose sight of what's happening. We ask questions, and I've been asking questions about our local surgery for 5, 10, 15, 20 years, and it always comes down to, well, there's a difference of opinion between the the owner of the surgery and the tenants. So there's a difference between landlord and tenant. Then there'll be a difference of opinion about or a problem of getting the GPs to actually go into the surgery and nursing. And so we never seem to get on top of this. We're always just asking questions and being told, well, it's going to be and yet this is yet another report, and it is full of good intentions, and of course we're going to support all of this, but we're frustrated because we're not properly, as members, we're not properly engaged in the process. I think it says the purpose of the report is to inform us of the process. I think most of us anyway would appreciate being more engaged with the process, so that we can give assurances to the people we represent that the surgeries are going to be there. I mean, I don't know what the answer is, but I can see what the problem is, and I think I'd be happier if we were actually more engaged with the process generally. Thank you, Chairman.
Chair, can I just answer a couple of those points?
Yes.
If that's all right. Thank you. I'll try and be brief. So just a couple of things. I think what we are updating you on is the process of doing the review, Councillor, because actually this is a significant piece of work to be able to actually pull together district by district plans, so that we are able to show exactly where the growth is going to be in relation to the current primary care estate and the state of that estate, in other words, where it needs improvement and work doing. I think that level of transparency when we share those, and once we've done that piece of work, will really help to be able to understand where surgeries are too small for their current population, where the developments are going to create real pressures. So I think that is the first part. I absolutely agree. We need an improved way of keeping everyone abreast of what is going on. But you just have to remember, when it comes to Section 106, sometimes we get £2,000, £3,000, £4,000 because of a few houses, and then other times there's multiples of millions available, which can build a new health centre. The process for where the premises may be or what's going to be developed, I think we need to include our intentions for that within the planning on each of the individual areas, so that you can see what the intentions are, because sometimes it's not possible to build a new surgery, other times an extension is necessary, other times you would need to build something new. Just one thing I need to add with this, which I think is really important. As we all know, increased building doesn't automatically mean increased staff. We have a shortage of staff across the NHS, and that's something that we need to be considerate of. But key to this is, if you don't have the premises, you'll never get the staff. It is an absolute certainty that when you have poor premises and you don't have enough space, recruitment is even harder. So we need to maximise the opportunity to get the best space, so we can have the right number of staff and bring the people in there to be able to provide the healthcare. So that is absolutely key. But I think fundamentally, Councillor, the point is about communication and making sure that there is an openness. This isn't done behind closed doors, but it needs to be more transparent, particularly when we share these are phases of the plan for what we are looking at, so that they are people are informed. Thank you, Chair.
Thanks, Tim. Just an anecdote on that. I mean, Tim and I met a number of times when a new medical centre was being built in Kibworth. The other district councillors, or the district councillor myself, had one idea, and Tim and the GPs in the practice that were moving into a new premises had a different idea. We had many discussions. So I mean, and that was several years ago. So I mean, if you want to, you kind of get into the discussions at an early stage, and that's what I would recommend. Once something starts to happen, you need to get involved. Rosita.
Hello. First of all, let me say that I really, really welcome this report, and that I'm pleased because for years my little involvement has always advocated this, because I really think there is a need to have a health family to work together and to identify the actual needs. Now, and I think what this needs to be so, and mainly my points or comments, it needs to be a living document, because we know that there is a government consultation on additional planning. So we are looking at this on the way it stands and what we've got before us, and it is a little bit of catch up. You know, we are playing now because there's a lot of development in the pipeline. However, you know, with it being a document that can be then altered, and once we have the basis in place, we can build on that if there is additional need. While I'm talking about need, and you referred to identifying it, but I think one of the things that also needs to be looked at is the individual need in districts. For instance, I have got a very high aging population, I believe the highest in Leicester, over 80. So therefore, the needs are different to where you have a very young population. But then on top of it, if I get my future development, there will be 40% of affordable housing and specialist housing. So that needs to be featured into the needs provision, so to speak. My other point, it is just, hang on a minute, we were talking about the need for new and improved premises. While and what I said previously, it's all very well, but do we then, or do you then, get insurances that once they have these improved premises, that they will also get the additional staff? Because, you know, it's all very well. And then the GP says, oh, no, sorry, you know, I'm not paying for another doctor because now I've got a nice surgery, value of my surgery and my property's gone up. But, you know, hey ho, you know, whistle for the staff. And therefore, you've made the point of self-financing, which I assume works. So you can explain that to me in a minute. And I suppose that is how it interrelates. Now, how and I don't see in your phase 4, it's not featured in, say, for instance, like hubs. So, as you know, I've got Lutterworth East pending. So we're talking 2,700 houses, probably within the next local plan, another 2,000 houses. So if the developer provides a hub, is there something featured into your phase 4 that would consider such a hub, and to have a satellite provision? Because I know, for instance, that satellite provisions, again, I've got one in my area, are extremely popular because it helps with the carbon footprint. It minimizes travel to the next you know, to the next nearest market town. In this case, you know, also it is more convenient for the elderly. And on that as well is one of the things I haven't noticed in your report is what Section 106 money should really do is it should provide things which are actually of benefit to the patients. So to me, if I have a lot of Section 106 money, it should provide for the surgery or for the hub some specialist equipment so the old people or whatever shouldn't have to travel to Coventry, Rugby, Leicester, so some basic treatment can be done. And then also it would cover the environmentally friendly thing to save on carbon footprint. And I think I'm done. I'm not so pleased about the increase in rent that should be absorbed within the Section 106. I'd much rather would also, or as well as, like to see, to repeat, an emphasis of providing some specialist equipment to cover the, to cover the patient care. Thank you.
Thanks, Lisa. Tim, anything?
Okay, I'm glad I had a paper and pen. Let me go through this as briefly as I can. Okay, so a number of points you brought up, Councillor. So yes, it does have to be a living document. You're absolutely right. If any document is considered a strategy, it's immediately put on the shelf, and then you are gathering dust. This has to be a document that we are constantly looking at, because things are changing all the time, and if the planning guidance changes, that could impact all of it. It doesn't change from the fact, though, that it'll give us a really good understanding of our current premises, where the issues are, and where we need to focus our attentions. Next point you brought up was about staffing. Now that's really interesting, because with you only get Section 106 with an increased population, and with an increased population comes an increased list size. With an increased list size comes increased income. So as you'll all be aware, for every patient registered with a practice, there is an annual amount of money that they get, and then other monies go on top of that, such as for prescribing or quality and outcomes framework, and a budget also for secondary and urgent care. So every patient gets X, it's £1,000 plus per year for a commissioning budget for that. So just taking the example of Lutterworth, as that is your constituent area, with an additional 5,000 or so patients will then come the funding that primary care will get. Now, ultimately, we all know that if they are seeing that many additional patients, the numbers of additional appointments that will take place, one, they need the capital for the estate, so they've got rooms to see them. And secondly, the revenue, as in from the NHS, will fund the additional staffing. Most practices are under huge pressure for appointments, as you will all be fully aware, so therefore will need the additional staff. Remembering that on top of the revenue we're talking about on a year-on-year basis comes the additional staff as part of the primary care networks, going back to my point of 13 per 50,000. So therefore that is really important. So it's not something we're needing to force, because actually in the vast majority of cases, increased patients equal increased staff.
Can I just ask on that? Does the doctor surgery have to provide it, or is it as their discretion? Because a doctor could say, "I'll keep the money," and and not employ the staff. So do they have to provide that staff?
They have to provide a service for their patients. We can't force them to buy so many GPs or nurses or what have you. That's not within our gift. It's individual practices have their own business models. But when populations increase, practices do pretty much automatically go out and advertise. They try and recruit, they try and bring new people through. So we can't force it. But if the service is going downhill because they haven't got the staff, then that's when we can be involved in talking to them about it. You mentioned another point about self-financing. Now, ultimately, I think just making it really clear, the NHS or the CCGs do not have any capital. We can't give them capital. So if they choose to expand their surgery and spend and take a loan out to be able to do that, before they were to do that, they would put a bid into us first to say, will you cover the notional rent? So will you cover the cost of this capital? Now, what you have to be aware of, and this really segues into your second point, Councillor, we don't get an uplift each year for premises costs. We don't get an uplift for new buildings. We don't get an uplift for notional rent. It always has to be found out of our existing budgets. And this is where it makes it very, very difficult. Capital is easier to find. There are many third-party providers who would love to be able to invest in capital because they get a guaranteed income from it. The issue from the CCG is making the decisions in relation to the revenue. So your point about rather than abating the rent, using that money to deliver other services, the fact is if we weren't able to abate that rent and reduce it, we wouldn't be able to afford it. Because actually often that money is having to be taken from existing budgets, and therefore there are difficult choices to be made. Which then comes down to your last point about where buildings take place. You mentioned hubs, and I know this is obviously a particular pertinent element to Lutterworth. I don't want to get into the specifics of that for the sake of the committee. However, just to be clear, economies of scale are very important when it comes to surgeries. The bigger the surgery, the more the staff in one place, the more appointments that can be provided, the more services can be provided. There are, as you will notice, fewer branch surgeries, fewer small surgeries, and practices find it harder and harder to staff and to provide services in the word you used, hubs, or we call them branches. So actually you're finding that actually they would prefer, because it is easier to recruit, it is easier to provide services and more appointments if they are centralised. So it's one of those it's a real dilemma of putting something right where the people are versus being able to get the maximum level of additional appointments possible. And that's where branch surgery stroke hubs are quite difficult. I believe I've answered all of your points.
No, two more. How about featuring in the individual needs, i.e. social housing, special care, aging population, and
that is taken, yes, that is taken into consideration. When we look at the housing, it's not all generic. And we looked at that when it came to the most recent bid for Lutterworth for Section 106, because you can't take into, a 1-bedroom flat and a 4-bedroom house will have a different number of patients and also a possible need. So we are looking at how we can be far more, we can scrutinise that more to make sure it's a more accurate reflection.
And my last point was specialist equipment that helps to provide specialist services in the surgeries to stop the carbon footprints of people having to, say, go to Coventry for an eye check or whatever,
Okay. So we have to be very careful not to mix our metaphors with this. What we're focusing on specifically here is primary care estate to enable services to be delivered. Now, we have a shortage already of clinical rooms to deliver core primary care services. So that's, the number one importance. You're absolutely right, and we do use our community hospitals to provide those specialist services. Some general practices do have those, but it is quite rare. So to put in that sort of diagnostic equipment normally requires a community hospital because it requires a larger scale or larger number of patients to make it viable. So that is a secondary element rather than focusing on this Section 106 for primary care space.
Okay, that is actually very important to know, because when you're like me as a counsellor and looking at the proper spending of Section 106, you see there is to what you just have explained to me and what a community hall or a tennis club provides, there is a difference, if you see what I mean. So that is very important to know the basis you have just explained, and it makes it a lot clearer. Thank you.
Good, I'm glad, Councillor. A pleasure.
Thanks, Rosie. Yeah, I think on this committee you learn over a number of years just how different the NHS is from our own county council and our own funding, etc. They are different. We get there. Ted.
Tim, you gave the scenario of an increase in population of 50,000 people, and you said for an increase of that size you'd be looking at 13 to 14 extra staff, and you said that they would have to be housed somewhere. So to summarise what you're saying, it sounds like you mean this is the point where a practice has to understand that either has to move or have an extension because that it reaches a certain threshold where it just isn't big enough anymore. Is that what you did? I
may not have made myself clear, Councillor. Let me try and clarify that point, and apologies if it didn't come across as clearly as it needed to. Not 50,000 new patients. So the rules for primary care networks are that for a population base, additional funding will be allocated for new staff. And I use the example of if you have an existing 50,000 patients, the NHS through primary care networks will award adequate funding to employ 13 new staff to be able to provide services for that population, not that money comes when there is an increase of 50,000.
Right, thank you. So, and the other question is what preceded this primary care estate strategy? Did you have an estates manager that was auditing something? What what came before this, and what led you to, what were the opening set of circumstances that led you to decide to devise this strategy?
In answer to your question, the last time we did a detailed estate strategy such as this was 2008. 2008 to 2010. So it's been a decade since we've done something of this magnitude. There has been work, obviously looking at growth and looking at need and looking at development. And actually, we've still been building on those practices, for example, that came up as red rated back in the 2010 survey, which we've still been looking at improving. And there are still a number of projects taking place which still exist from that survey. This was done for a number of reasons. First and foremost, it was timely. Secondly, NHS England very kindly funded the baseline survey, which was a costly affair to be able to do all of that work. And it's time, and we're looking at things in a different way. The way the CCG is structured, we want place-based plans. So district on district, every district and unitary authority. We therefore have a plan of what we're intending for services and premises, which therefore means that we can move into the new world of far more integration and transformation of services, working with you with an up-to-date estate plan rather than one that was out of date.
Yeah, thanks, Tim. Amanda. Amanda?
Sorry, having a few technical issues. My mute wouldn't go off. Tim, thanks ever so much for this. This is really useful, and I think obviously the final report, I'm sure, will come back to scrutiny at some point in the future. I think one of the things that strikes me from the report as it's written is there's an awful lot about growth in people, and I think one of the things that quite often gets left behind is the services that are provided to communities that are already there. And certainly we've spoken before, the surgery that covers my constituency has been in a situation where it's providing services for far more patients than what it's designed to already. So in a situation where we're already, I think it's about 3,500 patients more than the building can cope with. So I'd be really interested to understand it in terms of the language, and the terminology is very much about void and underutilised. And there's not a huge amount in there about where we already know capacity is at full stretch. I think the other real concern I have, and I've said this before, is the development of Lubbersthorpe had triggered an expansion of Warren Lane. But I do know lots of people from Braunstone Town and Thorpe Astley are moving to Lubbersthorpe. They will remain at their current doctor's practice until the new Lubbersthorpe doctor's practice is available. So how do we manage the capacity transition? Because obviously, you know, the new surgery in Lubbersthorpe isn't due to be developed till X amount of years of time. But by that point, hundreds more houses will have been built, and it's about how do we manage that transitional capacity until a new premise becomes available. And I'd be interested to see how this strategy, as it moves forward, recognises those two elements a little bit more.
Thank you, Councillor. Yeah, a really, really important point. So the first one, rest assured, one of the key factors of the Six-Facet Survey was square meterage of a building versus current population. So there is a statistic or a figure that we need to use from NHS England, which is every patient should have 0.08 meters squared. Now, I don't know how they come to that, but it's one that we use. Now, if you take that into consideration, we have many practices that would already be significantly under that for their current population. So when we go through the prioritisation process, one of the key things that we are working through, and I only had a working group on it yesterday, was how do we weight the current capacity for the current population? And we believe that has to be very high, because you're right, underutilisation is rare. And expansion and growth is obviously, growth is a really key point. But fundamentally, if you're starting at a point of not being big enough, then you have to consider that rather than just assuming that everyone is already fine, because we can't do that. So you are absolutely right to raise that. And it is a very large chunk of the weighting that we will use is existing space for patients. The second point you raise is really the hardest part for us. Quite often what happens with Section 106 is that the money comes in dribs and drabs, and it comes over, say, 5 years. The problem being is by which point a new surgery or an extension or a development of an existing premises may already be really problematic, because you've had thousands of new patients there. And it is the problem and the reason why more and more, when we're asking for Section 106 particularly, that we ask that we get it at the start rather than at the end. Because ultimately, if we have it at the start, we can then develop the services and expand into the space, rather than existing premises being entirely overrun with thousands of or hundreds or thousands of additional patients, and therefore making it harder. So this is where we have to work much more closely with you as our council colleagues and with the developers and with the district councils to make sure that we have, as best we can, the money up front to enable development to happen.
Yeah, that's useful. Thanks, Tim. Sarah.
Thank you, Chair. Seems like a long time since we've been waiting for this strategy, but maybe that's just me. So what I'm hoping is, Tim, that you can tell us come sort of early next year, you can come back and tell us what how it's all panned out, because according to your phasing on paragraph 7, by sort of end of December, we're going to know the premises and the prioritisation of work that we're hoping to see. Is that going to be the case? She says, being cheeky.
No, not being cheeky at all, Councillor. It makes perfect sense and it's within the plan. No, I think the reality of it is, now we can already see, based on the high level information of current capacity, growth, state of premises, where there are what we're calling them hotspots, and there are about 20 hotspots, and that's just looking at growth rather than existing premises. The aim of this is to have a very robust prioritisation process, and the reason for that is this is phenomenally emotive. It's emotive because it involves money, it involves difficult decisions, and I believe every practice, there can't be many who don't believe that they require more space, more rooms, and more ability to provide healthcare. So we have to do this very robustly. And I believe that having an appropriate prioritisation process that considers all factors, not just housing growth and current estate, will be really important. But that will only take us to a certain point. All it will do is tell us where we know with real granularity of where the issues are and where we need to focus our attentions. What will then take more time afterwards is then making specific decisions about what we do next. So making a decision about, do we build something new? Do we extend? Do we refurbish? How is it funded? That will then have to be done based on the areas. In some cases, it will be individual surgeries. In most cases, it will be areas to try and find the right solution for the future, which will then be done after that and going through detailed feasibility studies and costed studies. So what you will have at the end of the year, start of next year, is a real understanding of where the overall position is for the whole of Leicester, Leicestershire and Rutland. But it's then working out the so what and how we fund that, and which will take a little bit longer.
Yeah, quite.
Can I ask a quick question on that? When are you proposing to share the draft? Because rather than presenting the districts or the areas with a completed report, it would be rather prudent if they feed into the draft and help you with, securing the funding in time and, to just simply feed in with local knowledge.
No, that's a very good point, Councillor. I think first and foremost, at the moment, we haven't even shared this with our practices. We are just making sure that the information is accurate, and we're working through it, which of course we will share with them and with our primary care networks. The reality of it is the next phase of this won't be asking for money. It will be recognising where there is growth and recognising where we need to work very closely to be able to do that. And that will be incredibly important working with you. As the Executive Director leading on this, Sarah Prima, I'll have to work with her on a timescale and when we'll be able to share the information, when we'll be able to bring it to you so you can see it, to ensure that, again, that we have a process that everyone is happy with.
Mm. Thanks. Mukesh, I see your hand up.
Thank you. This is really a question about the GP surgeries or estates planning, nobody expected the pandemic to arrive so quickly and take us by shock. A lot of the GP surgeries have been forced to close their doors and make patients wait outside prior to their appointment. In some cases, you might be waiting half an hour or more. Now, that's okay in the current weather, but as we approach winter, there will be people that are elderly, frail, disabled, mums and tots. And, when we get high winds, rain and cold weather, it's going to be a bit of a challenge for people to stand outside to be seen. I'm just wondering if the strategy or the estates have considered that and factored that into their planning. Thank you.
Thank you.
Thank you, Councillor. Yes, so let me, it's a slightly different issue, but it's absolutely an incredibly valid one. We have been looking immediately or imminently over the last number of months on how we can support general practice who've had to make monumental changes to how they deliver healthcare. As we all know, with COVID, it has gone through a route of triage prior to people being booked in. The aim is to make sure that people go to the appropriate place, that you're not mixing those people with the highest risk with those people at risk of having the disease itself. So practices have had to take monumental steps to ensure that they cohort patients appropriately and make sure that people don't just walk in the door, because if you have one person walk into a door of a full waiting room, that could infect everybody in the waiting room. So that's why it's really, really important that practices have managed it appropriately. Now, of course, at the very start, yes, it was quite a lot of doors just being shut, but I know more and more there's been a significant amount of recovery work gone on to make sure that services are there. However, we still find that practitioners are in full PPE because they need to protect themselves, particularly over the winter, and that patients are triaged and asked to come in at a particular time. The world of walk into your surgery is currently not one that we see, and rightly so for everyone's safety. So I think what has to be absolutely clear with this is that this will continue over the winter, particularly if we look at what was probably going to be announced at 4:30 this afternoon, and a fear of the fact that we may have a difficult winter. So I believe that practices will still go down the route of triaging patients, seeing them via video consultation where possible, or treating them over the telephone where they are able to do so. But in answer to your point of what happens when patients do need to be seen, I think practices are doing their very best to ask all patients to wear masks when they come in, managing in that way, asking people to come at the time of their appointment rather than coming into the waiting room because that's inappropriate. And I think it just needs to keep the message that people shouldn't be queuing outside. They should be coming on time for their appointments, or hopefully being able to wait in their cars if that's necessary, if that's possible. If they do have to wait, obviously then it's the practice to be able to support them. But we have to understand that if we have a large outbreak amongst clinical health professionals, then that does create a capacity issue in the long run. So your points, Councillor, are absolutely valid. We do need to make sure that people are getting the care that they require, but it's one that it's a difficult balancing act between people waiting outside and people having overfull waiting rooms.
Yeah, thanks, Tim. No, I was speaking to the practice director in my area yesterday, and that's one of the issues she's going through, is what to cope with, particularly in the winter. And as you quite rightly said, it's timing a lot of it, and possibly waiting in their cars if there's a car park, which obviously isn't always the case as well. But yeah, thank you very much. Right, thank you, Tim. I've got no more questions. Thank you very much for that. We look forward to seeing that as it goes forward. So thanks very much, Tim. Nice to see you. The next item is the independent review of East Leicestershire and Rutland minor injury units, which has been brought to us today by Rakna Vyas, Executive Director of Integration and Transformation, or the 3 CCGs, probably, although Tamsin is done.
Yeah, so Councillor Felton-Ratchner's had to send apologies, unfortunately, but she's asked me to present this paper, and you will see from your agenda pack that it's actually a relatively brief sort of holding paper. So
page and a half.
Yes. So an independent a consultant was commissioned back in the middle of 2019 to come in and have a look at the minor injury sites operating in East Leicestershire and Rutland CCG, and did some work looking at premises issues, activity, etc. For a number of reasons, that work has not been taken through to completion and recommendations, partly because it dovetails with some work on the future of the delivery of community services in each of our geographies and places, and the community hospital offer that we talked about in my earlier paper, because most of the, I think all of the minor injuries units actually in the ELR are coterminous with community hospital services and delivered on those sites. So it's very difficult to take a view just about the viability of one service. You need to think about the overall blend of services delivered to that geography and the population that lives in it. The changes we've had to make to our urgent care landscape during COVID also now come into play as well, in terms of the need to separate out COVID positive or COVID suspected patients from the ones that are what we call COVID negative, and that's a similar issue to the one we just talked about in primary care. So what sort of premises do we need to be able to run both hot and cold streams effectively, and are the current sites fit for purpose on that? So I suppose in summary, we are doing a fundamental review of the community hospital offer, and the ELR services are located in community hospitals, and we are also doing a review of the urgent care model, which that sits with me to take forward. So we have not got a firm time frame for when we'll be able to come back with proposals on that at the moment, I'm afraid, but I'm very happy to be asked back to update you on that work or to provide you with a briefing as it proceeds.
Thank you very much, Tamsin. I mean, I noticed that Oadby wasn't included. Now, Oadby, I know, is different, walk-in centre, etc. But I know many people treat it the same as they would do going to Market Harborough or Oakham or Milton. What is Oadby not going to be included in this?
So yes, in the work that I'll be looking at, we'll be looking at Oadby as well as also the future of potential services in the south and east of the city. So so we're trying to take a more holistic view of this.
Yeah, lovely. Thanks very much. David, although you're from West Leicestershire, I see your hand is up.
Yes, I was actually wanting to come back on the last on the previous item. I'm still very nervous about the future sustainability of the primary care network, because surgeries just seem to sort of close as soon as they run short of GPs. They shut down. The system doesn't give me confidence that there's a basic stability there. Now this report that we've just looked at might just sort of reassure everybody, but I think we need to have more input into this as councillors. We need to really be given, if we haven't got confidence that the system is sustainable, then how can we pass on that confidence to the people who rely on these services and who come to us for advice? So could I simply ask that we actually see an early version of the work of the team that are doing this last report? Thank you.
I noticed Tim is still there. Are you able to reply to that, Tim?
Yes, I thought I'd hang on. You never know when you're still needed. And I wanted to be there to support Tamsin on the minor injuries if necessary as well. So I think, again, there's two separate points. The development of primary care networks and the resilience of general practice is linked to the estate's work. And I think they are all intrinsically linked. You can't have one without the other. I think the key element is, yes, general practice has become a very difficult place to work, and staffing has become hard, and it is a much harder job than I believe it was in the past, in the demands that are placed on general practice. But the whole point of primary care networks and the additional funding is really there to help support general practice with additional funding, additional staff and additional capacity. And by working in networks, they help support each other. So rather than it being individual practices, they are there brought together within a contract where they are working to support each other to help the entire population that they cover. So I think primary care networks is a very positive solution to support resilience of general practice, but it doesn't mean that we don't have to consider it in the long run. Now, the work that I've been doing and the work that will come through here isn't really focusing on resilience of general practice and primary care network development per se. It's looking at the estate element to it, but it doesn't mean that they don't need to be intrinsically linked. But yes, you're right. You do need to be involved more with how we're developing primary care networks and resilience of general practice.
Yeah, thank you. I would point out, I mean, bearing in mind we're county councillors, education, what happens if a couple of teachers go sick? Currently, they're closing the school in some cases. So there is an analogy, isn't there? In fact, I think health on the whole is more resilient than our education system. Sarah.
Thank you, Chair. It's a shame we haven't seen the report, even though it's kind of been superseded, because I would have been interested to know what they thought of those, what was going on there. And then the other thing, what are the 10 expectations? Because it talks about them. You know, we're seeing this part way through, and all we've done is make me interested as to what some of the detail is. So yeah, you know, I'd be interested to know that, so we can understand in a way, I guess, what's shaping what's going to come out the other end.
Yeah.
Thank you, Chair.
Yeah, thank you.
Yeah, so I can understand that. I'm not clear that there was actually a final report as such, but I don't know if Tim wants to comment on that.
Thank you. There was a report. The report was very long, and it did focus specifically on just the 3 minor injuries units of Market Harborough, Melton Mowbray and Oakham, not the urgent care centres or ODV, which are under a different contract, which Tamsin has said is being looked at. I'm not going to go through the detail. There are a number of options that it looked at, but I think, as Tamsin clearly mentioned, COVID has rather changed everything, and we have to look at the appropriate model for those areas, for all areas, to make sure that the urgent care system, whether it's minor injuries units in the daytime or extended access in the evening and weekend, is providing what patients require.
Yeah, thanks, Tim. Yeah, I understand that. Rosita. You're muted. We cannot hear you.
Now I'm back.
Now we can.
Yes, I was wondering. Yeah, you just referred to the report, but could you just, in very short, explain to me what the set of the 10 expectations were and what the outcomes you expected from this commissioned report? Thank you.
Okay, so they're 2 separate things, I think. The 10 expectations referred to in the report are the expectations that the health and social care system in Leicester, Leicestershire and Rutland have set themselves for COVID recovery. So, to really shape what the post-COVID health and care landscape looks like. Now, I have read them many times. They ought to be absolutely imprinted on my memory, but I'm not going to be able to quote all 10 of them without getting some of them wrong. But they are things like patient-centred, keeping staff and patients safe, moving care closer to home. I can share those with the committee if that would be helpful. And they're the guiding principles that will shape the design, not just of the urgent care landscape, but all other services. Yeah. That's that. The second question, can you just remind me the second question?
Yes, it refers to the outcomes. What are the outcomes of the independent review for the 3 minor injury units?
Yeah. So I think, as I was explaining and Tim was just fleshing out, there was never a confirmed outcome in terms of recommended options that we wanted to put forward. So I think the report was probably more discursive, and the options now need to be seen in the round with the configuration of the wider delivery of services to different geographies, and therefore we feel it's not relevant to actually put forward those options as standalone options. Plus, we are also looking at the other urgent care services that surround the East Leicestershire and Rutland, including within the city footprint. So it's basically back to the drawing board, and I understand that might be frustrating, but that will, I think, lead to a better outcome at the end of the day. I don't know if, Tim, there are any aspects of the review in terms of just collation of information that you feel might be shareable, but I don't think that the options are felt to be things we want to engage on.
No, just in brief, what it did do is really analyse patient flow, where people go in hours and out of hours, particularly the in hours part. And it put forward about a dozen different options of how minor injuries could be considered. But the fact is, none of them were so specific that you would automatically say, yes, we would do that. As Tamsin said, it provided a lot of background data, but not a definitive outcome. And then, of course, COVID came. So we have to then reassess what of that we can then use for the future.
Yeah, thanks very much. No, I think I understand that. OK, thanks very much, Tamsin, and thank you very much for staying on, Tim. Very helpful there. Thank you very much. We move on then to item 14, which is our very own Director of Public Health, Mike Sands, who's going to give us an update. And as you will see, the screens have cleared because we're going to have a slideshow.
Yep, thank you, Chair. Now, can you see that presentation?
Yep, I can. Yep.
Right, that's bad news for me because I have a problem with my machine today, which means I can't actually see the presentation I'm about to give, which is a bit of a drawback, isn't it?
Do you want me to move the slides for you, Mike?
To be honest, you can do what you like with them. I just can't see a thing at the moment. So.
You have to give the talk as well.
Yeah, I don't know what's happening. Let's see if screen.
Right.
Mix and match between the two. Bear with me. I'm just.
It's all this slow broadband up in Nottingham, isn't it? That's the trouble.
I had an issue with it earlier on. It normally works fine with screen sharing, but I've got a bit of a problem with my settings. I can't see it. No, let's find it. There we go. Right. So if I go off my pack, and then we'll do that one. So hopefully you have got the first slide, which is the title slide.
Yeah, we're on the purpose now. Yeah.
Presentation. Right. Okay then. Right. I've realised the mistake I made was writing this last week when I thought this is wonderful. I've got a fairly upbeat position to tell in terms of how things have changed since the last time we met as a health scrutiny committee back in June. An overview of the current situation, and then just giving an idea about some of the stuff that we've done to respond to issues, notably in Oakham, Wigston, but also in Melbourne. Of course, that was tragically the wrong thing to do because it's all gone absolutely belly up since then, but never mind. So on to the next slide, if you can, Ewan.
Yeah.
And again, as I'm going blind, just give us a nod if you can see the next slide.
We've got data and capacity.
Thank you. So I think clearly last time we met, I would have given an update on COVID. We would have talked about the numbers of cases, which of course tragically back then was the kind of weekly updates on the numbers of deaths and the numbers of Pillar 1 cases we had coming through. Since then, it's only been 3 months, but there is a good news story to tell, which is we've really moved from famine to feast as far as data goes, and actually extending that into being able to do really what one would have wanted to have done from the start, which is basically our own local epidemiological work and investigation. So it wasn't until the end of June, on the sort of June 27th, 28th, that local authorities, ourselves included, started getting releases of postcoded data on cases. So you'll recall, or members will recall, that that's at the time we then started doing the all-member briefing updates on a Tuesday, which included those maps at middle super output area level. So that postcoded data was a real breakthrough to at least enable us to understand where the cases that we were getting within Leicestershire were living at a level below anything we had up till then was cases at a sort of district, whole district level. Obviously, there's always a bit of a shame that actually that was exactly the weekend that the Leicester Lockdown was announced, and clearly we had 100,000 people in our population pulled into that lockdown zone. So it all got a bit wrapped up into conversations about the boundary and the wherewithals. But actually, if it wasn't for that, I would have been celebrating that weekend the first step towards beginning to give us some data. That gave us something, but clearly it just kind of told us where cases lived. It didn't tell us exactly where they would have acquired the infection or whether it was related to a particular outbreak, etc., etc. But it did allow for a feeling of being able to stand up hypothesis along the lines of, is there a geographic link to these cases? Is this sort of small community clustering? And because we had the individual level data, you could tell if you had 4 cases linked to one separate postcode, so full postcode data, that, although it wasn't certain, you could make a reasonable assumption that that was a family in a particular house that had gone down with it. And that told you a bit more then about whether you were seeing kind of clusters of households that were going down with it. Also at that time, what we now get on a daily basis was access to some of those more detailed Public Health England and Joint Biosecurity Centre products, should say JBC, not JBS, which includes things which we've probably all become familiar with now in the press, which is the rankings of the top 20 areas of concern, those areas with the top 20 highest rates within the country, their positivity rates and the rest of it. So through July and August, that carried on. One of the more positive side effects, let's face it, there wasn't an awful lot of positive side effects of Oby and Wigston being in the Leicester lockdown. Wigston became part of the localised contact tracing pilot. So within Oby and Wigston, that's when the cases that the National Test and Trace were unable to get hold of passed to us as what are called FUFs, follow-up failed, to do the local contacting. And of course, in and of itself, that was a really good thing to do. It meant we moved from the kind of 60% of cases being NHS above 90%, and I'm sure members of Scrutiny will be hopefully familiar that was something to do with that kind of personalised approach, so being rung by an 0116 number as opposed to the sort of national 033 number, whatever it is, and indeed if we don't by phone, actually knocking on doors and contacting them. So as a quality improvement, the ability to take forward some of the localised contact tracing was really, really very good indeed. But then separately, or as part of that, that also meant that we started getting in sort of mid-August access to CT contact tracing data. So we could then see two bits. So we've got this individual case data, which is telling us full postcode level data around the cases, but we've also got some contact tracing data, which again tells us where people will have been contacts and where they will have gone and whether there's any links. So that then enabled us to join it up and start putting together our own investigation and hypothesis, partly because on the free text field of NHS Test and Trace, it gives you some information about where people may have been or where people have been and may have contacted the virus, whether they're returning holidaymakers, whether they've been to a particular retail place, a particular pub, or where they've worked or whatever. And you can then do a bit of fuzzy matching between the contact tracing data and the case data to actually look at links between the two. So you start to some extent building up your own hypothesis about where local spread has happened. So it's pretty, as I say, it's rough and ready because with our analyst, Natalie, I think some of you, well, you'll know Natalie from when she's done the data reports, has been working more with us as the kind of lead for our local field epidemiology service. And sure Natalie wouldn't mind, I'd never pass myself off as replicating what Public Health England do in terms of their field epi service, which is incredibly detailed and skillful service. But actually through Natalie's work, a woman called Natasha Pickering, who started with us working as the lead for our localised contact tracing service, and then me and my team, we are at least able to take some of the load off Public Health England and step up our own epidemiology service in the way that I've described, that kind of looking at links and trying to look at what's going on. We also got through August the tranche of money, the £2.3 million into Leicestershire to cope with COVID from a public health point of view. And we've not only put that into the local contact tracing capacity, as I said, but we've invested, we're out to advert and appointing additional infection prevention and control specialists to support care homes and other settings. And that's also enabled us to extend some of the local area coordination work, where again, that's providing support for the vulnerable, support for the shielded, which, shielding's now paused, but that's now become the vulnerable bit. So next slide, please, Ewan. Then this one, summer hotspots. Yeah. Yes, this is the days when we just had one or two issues to cope with, which we dealt with. So I probably don't need to say too much about Oby and Wigston, because I'm sure you'll have followed that all the way through the summer. But worthwhile knowing that up until the last few days anyway, Oby and Wigston's numbers when it went in as part of lockdown was in the mid-30s per 100,000 population. At its worst, it did peak at around 80, and even I would say I kind of I was so busy doing stuff for kind of those days, I almost kind of like, oh, didn't quite realise. But if you think of, I think Bolton, at its peak, Leicester was 135 for 100,000 population when it went into lockdown. I think Bolton yesterday was above 100. Next highest in the country yesterday was about 70 or 80. It gives you a feel that at its peak week, Opie and Wigston was up there. It was always in the top 10 areas of concern in the country, but it certainly had a few days when those numbers really got quite scary. But that work that we did, which I'll go into some detail about in a minute, around the comms, the engagement, the massive amount of, or the not the massive amount of testing, the massively good response we got from the general public to our call to get tested if they had symptoms, and in some areas to get tested even if they didn't have symptoms, really worked. And just after Opie and Wigston came out of lockdown, it fell back to below the national average, actually around about 10 per 100,000. That's now gone up to into the mid 30s again, or nearabouts, but clearly there's a number of other things going on. I should just mention again, whilst I'm talking about summer hotspots in Opie and Wigston, that on the peak day of testing in Opie and Wigston, we delivered probably, well, it was 20 times the national average in Opie and Wigston. And even that was about 4 times what Leicester City were pulling out. And it started out as a bit of a joke between some colleagues. I wasn't on a meeting, but I kind of dialed in halfway through when they talked about Opie and Wigston having the world leading amounts of testing. And actually what started out as a joke, I think a few people looked at it, and of course it's not fair to compare areas across areas, but it's probably, it might just be right that on the peak day in Opie and Wigston, that was the place with the highest rate of testing per head of population in the entire world, which is a hell of a testament both to local people for responding, but also my team and colleagues within the County Council and within Opie and Wigston Borough Council. In terms of other hotspots, we got through that one. Melton, again, you'll have seen that we had a particular issue in the middle of Melton Mowbray, where the figures there went up rapidly. And again, we learned from Opie and Wigston and stood up very rapidly a more localised programme of increased testing, comms and engagement with a particular population in the kind of north and west of Melton Mowbray, and that was really useful as well. And then we move on to August and September. So when I wrote this last week, Blaby and Osby and Wigston are areas of concern, and we had what we've been calling a general rising tide, a little bit of an upward trend across the county. Clearly, things have escalated very rapidly in the last few days, not just locally, but across the country. And members of the Scrutiny Committee will have seen the announcement last night about social gatherings. And indeed, 79 minutes till the PM allegedly does his further statement at 4 o'clock. So we'll see what's in there. But things, for whatever reason, and I'll speculate as to why that might be in a minute, have clearly escalated again in the last few days. So this is unfortunately somewhat out of date, but I'll go through that. So on to the next one, please, Ewan. And this should be general points. Yep. And general points, I'll take something on this one because obviously I did write this last week, but if you think about what was said yesterday in terms of social gatherings, for a little while locally, I've had an issue that we talk about particular outbreaks, Green Corps in Northamptonshire. Locally, there's been coverage of the outbreak in Plaid, Melton. But actually, my real concern has been around transmission within informal settings. We know we've had an issue with people returning from holiday. I only think that's half to do with going to places with higher rates of infection. I think the clue's in the title. You're on holiday. You're less likely to be doing your social distancing when you're there. We've talked about issues around workplace and it not necessarily being in the workplace, but actually around car sharing on the way to work. And equally, you know, there's an issue there for me around household transmission, so house parties, household gatherings, particularly in younger people. And I'll add into that some of the stuff around behaviours in pubs, so, you know, social distancing inside pubs, outside pubs if they're queuing in, you know, vertical drinking establishments and nightclubs, and also retail. So any area where you forget, it's almost like if it's regulated, if it's controlled, if people are thinking about it, they remember social distancing, but in those bits where you're not thinking about it, that's where it inadvertently breaks down. And I think in terms of the social gathering message last night, then you can see that basically what we're on to locally is being reflected nationally. We were ahead of the curve in terms of local resilience forum in thinking on a rising tide strategy. So trying to find new ways to say the same old message around social distancing and hand hygiene. But actually, at the end of the day, it's not necessarily about lockdown or about restrictions. It's about getting people to remember to do the right thing. And that's much more about behaviour change and much more about trying to get those behaviours right, which is more around understanding where you need to advertise, how you communicate, and just instilling that behaviour. So we've been working on that. I think we're ahead of the rest of the country in working on that kind of a strategy, but it feels like we need the rising tide strategy in place now, as opposed to in a month's time. And then just, again, this has been covered locally and nationally. What we've seen for some time is that Pillar 2 testing, community testing, has got a markedly younger age profile than the clinically prioritised testing, the Pillar 1 testing. Overall, it's around about 40, but actually in the last couple of weeks, I'd say the majority of the issues we've had have been even younger than that. It's been in the 18 to 34 age group, and particularly the 20 to 29. So maybe in the context of schools going back, people might think there's been a particular issue around school-age children. It is actually a little bit older than that. 20 to 29 is the single 10-year age band, which concerns me, both men and women, to be honest. Sometimes more women, sometimes more men, but that's where we are. So on to the next one, please, then. Ewan, which should say threshold of indicators. I could go, this again is probably largely out of date at the moment, just to make you aware that the I've had a number of questions going, well, what do we look at when we decide what action to take where? And to be honest, there's not one indicator. It tends to be a variety. You look at this 7-day incident rate, so the rate per 100,000 population of cases per 100,000 population. The starting point for action was at 20. That's a little bit more difficult to hold at the moment when the national average and indeed the local average has moved up from round about 11, it was about 11 for Leicestershire and the national average up to about just short of 20 as of yesterday. So that's becoming increasingly difficult to actually say, well, the threshold for action is here. But you do tend to look at things like the rate of positivity of testing, the incident rates. You also compare what's happened in the last 7 days with what's happened in the last 14, because that gives you an indication of the rapid rise up from 1 week to the next. And some of that, of course, is bounded by situational awareness. If you can pin it on a particular outbreak in a factory, that's probably less of a concern than, frankly, what we're seeing at the moment, which is not necessarily any particular links with any one particular geographic area or situation. They are single cases which are bubbling up in a lot of different places at the moment. And so just to reassure, so I could do an entire one on that one, but I won't do, just in terms of the number of indicators that I look at day by day.
We actually missed that slide. It's right. Ewan's obviously having a techie problem.
Sorry, it froze. I'm just trying to reload it.
Yeah, so, but it sounds like you've given us the verbal version of it, so that's fine.
Yeah.
So I think we're up to slide 8
My
or 9.
next one should be the opium example.
I think it was 8.
Yeah, about 8 or 9, wasn't it? Yeah. I was just on the verge of taking control and it vanished.
No, it seems to have frozen. You might have to just carry on, Mike.
Okay. So I'll just refer to the meeting pack then, because hopefully you've got the meeting pack in. I will sort of skip. I mean, to be honest, the rest of it, I just wanted to go into a bit more detail about what we did in Opie and Wigston. If you, I think it's page 42 of the meeting pack.
That's right. So
you can see, in terms of ways of working, what I now do more or less formally or informally, is stand up what I call an IMT, an incident management team, which involves members of my team, comms from Leicestershire County Council, and then pull in appropriate borough and district council colleagues, so comms, engagement, enforcement and regulation, the EHOs, and indeed the chief executive. And this is what we first did in Opie and Wigston, to work out the comms messaging that we wanted to put forward, and then develop comms leaflets, etc. around that. The testing strategy, when we're able to do testing, is obviously a little bit of a move point at the moment, in terms of moving testing to where it's most needed if we need to, and then using that public health intelligence to come up with a list of postcodes which is sort of most desirable to do, and also working with the voluntary sector to think about engagement. So in Wigston, we had the volunteers that were knocking on doors to drop leaflets in that. That set the routine, which if the rest of it just kind of gives you a timeline. We've then used that, as I said, to really sort of refine it and do that quickly within Melton. And variations on a theme now in Blaby as well. The difference being, I guess, which was with Oby and Wigston and with Melton, it felt like we had a defined issue. The issue for Oby and Wigston was high cases across the whole of the borough, so we need to get testing done across the whole borough. Melton was focused on a particular area, so it was test comms in that particular area. At the moment, given that we've got a increase in cases nationally and an increase in cases locally, then it is almost more difficult to know what to do when you've got a more disparate spread to what's going on and what's going up. But the routine still stands, which is to put together a meeting, an incident management team meeting with district and borough council colleagues and county council colleagues, and stand up actions as appropriate. So we got that pretty well rehearsed and working very closely with district and borough council colleagues. But if it's frozen, I will end there, and that probably says all I need to say anyway. In terms of
thanks, Mike. Yeah, well, we do have our agenda pack, which has, as you say, the detail of everything else and about the MTUs and so on. So it may well come up with questions. Jonathan, I think you're first.
Thanks a lot for that, Mike. A couple of questions, really, both linked. The first one really is about the data, because obviously a lot of the data we're looking backwards. Sometimes a lot of the stats that we're referring to are probably of people who actually ceased to be contagious, because actually, sometimes they're 2 weeks ago, they may have been 3 or 4 days into their symptoms before they actually got tested, and they're probably, by the time we're actually looking at some of the figures, they may even have been through the other side. And I appreciate it's trying to give us an idea of where we're heading. But certainly at the moment, in the last week or two, as you've indicated, it's been a pretty rapid change, not always obvious, but also reflecting part of the national picture. There clearly is an issue with testing capacity. We can see that locally, but also nationally. I know you're aware of some of the issues about residents being given testing centres well over 100 miles away, and home kits not always being available. We've got students obviously coming back through our schools. It may well be that it's going to be a few days before we fully get a picture of how that's going to reflecting in some of the figures. But we also have Loughborough University coming back, 15,000 students, all within the target age group that you've set out, all appearing in a market town of 65,000 people within 3 or 4 weeks from now. I've seen sight of the Vice-Chancellor's letter that he's sending out tomorrow to all students, reflecting on the Prime Minister's statement, which he's just about to give. I know we've applied for a testing station to be in the middle of Loughborough to try and support the expected rise in required tests from the students, but also from the locality as well. So it needs to be accessible not only from students, but also for residents. Do you know how far that's got? I understand it's with Deloitte. I don't know whether you actually got an update.
Yeah, so probably a few things in there. Data-wise, we're not as behind the times with the data as we used to be. So what's in the public domain will be 7-day data, looking at the average of the 7 days that ends on September the 3rd. But actually what I've got access to, which I can't share, the data window isn't complete. So it's not published publicly because, there's a bit of a data lag and case data goes in. But it does allow me to at least look at basically what's coming down the pipeline in the last few days and work out which ways the things are going. So, and particularly in the last few days, it's almost what's happened since the 3rd of September. This is more important than what there is, and that's clearly influencing some of the thinking nationally and some of my thinking locally, particularly around Blaby, Harborough, and indeed Oby and Wigston. So that's much more timely than it used to be, when it did feel like we were looking back a fortnight. In terms of Loughborough Uni, again, it's like schools. There is a risk there, but actually university is the one shot, it's the one shot in life you're going to get to go to uni, and it's really important that students do get the opportunity to do that. Otherwise, potentially COVID will end. One of these days COVID will end, and I'd rather not go and knack up people's chances by not going to university. But it is a large number of people. We've been working closely with the university and with Chelmsford Borough Council colleagues around the plan I think Charnwood in particular, Borough Council colleagues have been really good doing that, working not just formally with the university, but actually thinking again about some of those informal things, so message giving in halls of residence, etc., etc. My concern would be, like all these things, not actually within the teaching environment, which I think where it's not regulated isn't right, but where there's a control, where it's paced, where it's measured out, that is fine. But it is trying to impress upon students, like any younger population, about where things break down. So informal gatherings, social gatherings, house parties. There has been, of course, a clamour really from a number of sectors to have mass testing. And I don't want to go into the science of it, but mass testing of a population using the PCR test in a low prevalence environment, so pretty much where less than 1% of the population has got it, you run the risk of getting quite a substantial number of false positives for every true positive. So when people go, we need to be testing everybody every week, I sort of groan thinking, no, you're just going to go and shove people into isolation for no good reason. So what we've done with the uni is to make certain that there is what is needed is to deploy testing rapidly if we needed to in a target population like university. So in terms of specifically coming on to answer your point, yeah, the Deloitte's LTS, it's called the local testing site. I think we've now got an approved business case for one off Deloitte's, and there is a site, I forget exactly where, it's not on the university campus, but it looks like it's been approved and it was within a mile of the university campus.
It's the Browns Lane car park. Yeah, it's where the temporary one was before.
Yeah, so basically that's an ideal hit for me because it does mean, A, it provides some form of semi-permanent capacity for Charnwood residents, because of course it would be for the general public, not just the university population. Sure. And if we did see an upsurge in cases within the local area, of course, then students would be able to access testing as quickly as they could. Hopefully, of course, by the time university goes back, we'll have got through the current national squeeze on testing capacity, which I'm sure members of the Scrutiny Committee will know is actually a bigger problem across the country. So from a Deloitte's point of view, I think what we've done in Charnwood is what I'd want to see across the whole of the county, which is to have a number of these Deloitte's-led LTS sites in each, well, at least one per borough or district, to provide some form of semi-permanent presence in a way that we've been dependent on the travelling circus of the NTU that's been revolving around sites like County Hall and Glenfield at the moment.
Yeah, thanks very much. Amanda.
Sorry, I'm having real technical problems today. First of all, question around testing. I mentioned earlier that the Blaby numbers are starting to increase, and that's obviously something that's a concern to myself and to other councillors who represent this area of Leicestershire. But I understand that the Blaby testing centre is at County Hall, which is about 3 miles away from sort of the edge of Blaby, in terms of where the hotspot element is in Braunstone Town and Thorpe Astley, we think. Is there any plans to move it?
Straight answer. Just make some
Sorry. No, it's fine. No, I'll go on to the next bit in a sec.
So the straight answer is no. We did do so there are a number of requirements around the sites that an MTU needs to do with the amount of hard standing, etc., etc. So we did work with all districts and boroughs to try and come up with a number of sites that we could use, and the one in Blaby is about as near as we're going to get to it. What we need to do is almost coming back to Mr. Morgan's point earlier on, is to identify those sites where we can put the more semi-permanent LTS as opposed to an MTU, and whether we can get one of those into Blaby, in particular Braunstone. It's a conversation I was having with Josh earlier on. A bit like, again, it's the work in Charnwood. We do need to put together a business case, which is to do with it being, an area of increased incidence, and then work through that and see if we can get permission. So the short answer is I'm not in a position to redeploy the Glenfield one into Braunstone, for instance, but what we'll work on and what we're working on is trying to get the same kind of solution as we've done in Charnwood into an area of Blaby as I would the rest of the county.
Yeah, I mean, obviously there's 2 park and rides that are sitting in Blaby, so that they might be suitable solutions. I suppose the key thing for the 2 areas that where we've seen an increase in Blaby and Braunstone Town and Thorpe Astley is 2 of those areas. What measures are being put in place to try and encourage social distancing again, mask wearing in places like Foss Park, Asda's Sainsbury's. I mean, that is a real sort of melting pot of lots of people congregating for a period of time. I think we're getting out of the habit of being good with our social distancing and our mask wearing. So how are we going to get that message across? Particularly with it's been in the national press, but it's not something that is fairly uncommon in our local press, is that our school buses, bus stops are becoming pretty chocker packed, as well as the school gates being of real concern. And the second element is, have we seen an increase of numbers occupying hospital beds? And are we, at the moment, is community transmission turning into more bed capacity being used?
The second one is, well, I'll do the second bit first because that's fresh in my mind. It is, I think I've probably said in other meetings before now, it's a question I asked the Chief Medical Officer a couple of times, because even in the middle of the Leicester lockdown, we had in Leicester the highest sort of instance in the entire country, and that was the same for some weeks, but we didn't see it flow through into increased hospital admissions. The CMO was more cautious about that and said that based on some American experience, that it could take a very long time for cases in the community to translate into increased cases within vulnerable populations, hospital admissions, and indeed deaths. And looking at the Pillar 1 testing in the last few days, which is this clinically prioritised testing in care homes and hospital, and I'm just beginning to see a small increase in Pillar 1 testing within Leicestershire. So to be blunt, I am fearful that what we're beginning to see is the start of it to some extent, although the age profile is really younger, and that's my area of concern, beginning to see it get into vulnerable populations. So it does feel like today is a bit of a red alert day, that this is the last chance. So it's slightly distracted by watching Boris at the moment out of the corner of my eye with the national conference too, that this is the red alert to take the one final step before we get into a second wave and we see deaths going up. Deaths haven't gone up locally, but I'm sure you'll have seen, I think the figure yesterday was 30 nationally. The average 7-day rolling average was 11 across the country, and it's only marginal, but I think the 30 was the highest single daily total for about a month. So there is some signs there that it's beginning to spread into it. Mask wearing is an interesting one. I mean, I talked about this rising tide, and really it's about trying to find on the nice way of doing it. I mean, all of this is like policing with consent. None of this can happen without the consent of people. You cannot, at the end of the day, impose order on people if they don't want to do it. So rising tide is about trying to find more sophisticated ways of trying to reach out to younger people to get them to do the right thing in the way that I explained. But then when it comes down to enforcement, it is a mix. If I take Fox Park, it's not within my say-so or Blaby District Council say-so to make people wear masks, because at the end of the day, the site is owned by Crown Estates. And then the conversation I know I've had with Blaby colleagues, which I've shared informally, and I'll do it, I know it's a public meeting, to start at Foss Park and stand outside M&S and look at the percentage of the population that shop in M&S that are wearing masks. And then by the time you walk down to the other end and you've got Primark and look at the younger demographic and the percentage of that group that are wearing masks, it drops off quite markedly. And I know that the security guards there, for a number of businesses, the message from the head office is quite understandably, ask once, but if you're challenged, don't bother asking again, because people do get aggressive. And I think it's very difficult for shop assistants who, it's not their job. If I think about the ones down Sainsbury's, if someone turns around and tells them to F off, then basically, it comes down to behaviour. You can't impose it, and actually to risk violence isn't something that I'd recommend. So we need to find ways of doing it. Maybe we do need a bigger stick to make people do it, but it is a difficult one.
Yeah, no, thanks, Mike. Yeah, understandable. I didn't know whether, I know I've not been asking you, Lee, but you haven't put your hand up anyway, but I just wondered if there's anything you wanted to say as the portfolio holder over this whole thing.
I think Mike's covered it all. I think it's just getting that message back. I mean, the message hasn't changed, and the need for us to sort of take those safe steps has never changed either. And I think it's just reinforcing that, and it is across age groups. I think the concerns of everyone that is looking to universities, schools, etc. It is, again, educating parents at the school gate. It's as Mike said, with universities, and listening to Jonathan earlier, it's about, I think the formal university campuses can sort of marshal or sort of regulate, but I think it's when people go into the private settings, it's that education to say that, yeah, we do need to do that. So, but yeah, I think we've got a job on our hands going forward. I mean, just one comment on the mobile testing unit. It is called the mobile testing unit because obviously people are expected to drive, and I'm not too sure what the usage figures have been because I haven't seen them across the Birstall one or the Glenville County Hall one, but I'm sure they're being still well utilised, else they would be moved very quickly to areas where they would be needed. So, and I'm sure Mike could confirm that as well. So, but no, nothing else to add, Chairman. Thank you.
Thanks.
Yeah, just on that, I think most people are aware that, you know, the issue really is Sarah Jane Marsh, who's working with Dido Harding at Test and Trace. The issue is lab capacity as opposed to the slots at the drive-in centres. But certainly, I think the OB and Wigston site has gone up from about sort of 80 tests a day up to about 200 or 300 in the last few days. So, you know, the test slots, wherever they might be, are getting well booked up. And to be honest, 90% of them are getting booked up for the night before, you know, so by the end of the day before people want to test, there's a good 90% plus the test slots have gone. So the test slots are maxed out. And then that's maxing out the lab capacity. I should say, because there is a really important message to get across to anybody who is watching back at home, that there is something along the lines of 44% of the slots in OB and Wigston yesterday were taken by people who didn't have symptoms. So they're either people who are in isolation and think that if they have a negative test, they'll be allowed out of isolation, which is wrong, or they're people who are gaming the system and think that they're entitled to a test every fortnight because they think they're entitled to it. So there is an issue which needs to get across to people, which is particularly when the system is under strain from a testing point of view, only get a test if you're symptomatic, because those are the people who need it. And that I think is the only way we've got of freeing up some of this logjam in testing at the moment.
Yeah, no, thanks very much, Mike. That's very important. Totally agree with you. Okay, that's very good. I think that we can let you go off and have your cup of tea and watch Boris. That's right. I'm recording it, you see. So.
No, I'm just sorry. I'm just looking out the corner of my eye, thinking whatever I've just said is probably out of date about 5 minutes ago. But never mind.
Well, I've got a machine that lets me instantly do it from my phone. Thank you very much. Then move on to the final item, really, which is the Health Watch Leicestershire Annual Report 2019-20. It's on pages 47 to 78 of your packs. And Mukesh Bharat, who we met earlier, our first time, is here to run us through it on the basis we've all had it now for a few days. Hopefully we've all read it.
Good afternoon. Thank you, Chair. I won't go through each and every page, as you will appreciate. You've all probably had a good chance to read it through. The annual report covers the work that Healthwatch Leicester and Leicestershire have been doing. Some of that work is before my time, so I shall endeavour to answer any of your questions as best as I can. Our Health Advisory Board consists of voluntary members who sit across a range of committees and meetings, and their primary role is to scrutinise in a positive way and make sure that the patient or the public voice is taken into account, and that any issues affecting the patients and the public are taken into consideration. As I mentioned, we cover the Leicester and the Leicestershire patch. However, I am mindful that we had a key member of staff who covered the Leicestershire patch who went on maternity leave and has just returned. And another member of staff who covered the Leicestershire patch who about a month and a half ago went on to a new job. You know, what we're doing is one of my sort of priorities as deputy manager leading the community outreach lead team is to have the next 2 quarters focused on work across the county. Clearly, we all of us have been affected by COVID-19, and as most of our work is primarily focused on community outreach work, we've had to adapt to remote working, and that's been very difficult to do in terms of engagement work, because not everybody's digital, online, confident, and not everybody has computers and familiarity with Microsoft Teams or Skype and Zoom. So we are working remotely. We are taking answer phone messages remotely. We have seen an increase in concerns from patients about access to GP surgeries. So one of the common ones is where people are waiting for long durations to get an appointment, and then they reach a point where they give up and they don't bother. Now that's quite worrying, because some people may have serious health conditions and they do need to speak to a GP, and we have raised the issue with various health colleagues to say something needs to be looked at in terms of encouraging people to keep their appointments with hospitals where they have long-standing conditions or they're vulnerable. We have done through our volunteers, we used to do what we call enter and view visits into different services. Now, clearly, we can't do that with the COVID-19 lockdown, but just before the lockdown, we did do some reports on the discharge lounges at Glenfield Hospital and Leicester Royal Infirmary. We were able to make quite a detailed analysis of issues that were taken on board by service providers, and that has led to some positive changes and changes in terms of how patients are discharged, and we're sort of going back and revisiting what has happened since. So there's a bit of a review going on there. We had planned further visits, but obviously the interview program is something that we can't do at the moment. So we are looking at working with our volunteers to say, okay, is there something else that might be done? Now, as I understand it, University Hospitals of Leicester have invested in tablets or iPads, and they will be allocated to patients, single use, and there will be risk assessments and a criteria for how they are used. So that might provide an opportunity for us to reach in to get the feedback of patients and their carers. The other one, of course, is where we have traditional hospital radios, and we're looking at how we might be able to have a health show where people can listen to health topics from their hospital bed and then call Health Watch and have a discussion with our staff or volunteers. Another issue that seems to be quite common is where people that are registered with a GP surgery are all of a sudden told that you're out of catchment area. Yeah. And that's one that I've experienced myself, having lived round the corner from a surgery, and the rest of my family's registered at the surgery. But because I went and worked out of town, all of a sudden, even though I still have the substantial home, I'm out of catchment area. So that's sort of worrying. It's happening to a lot of people. I shall move on to some of the research projects that we have. At the moment, our Health Advisory Board have decided to focus on mental health, which was known as mental health in crisis, but they've changed the word from crisis to urgent care. So that makes sense. We're doing a lot of work around raising awareness of what is mental health. Now, one of the issues is that stereotypically, people think of mental health from the old, sort of stereotypes of people with mental health issues and so on. But what they don't consider is health and well-being in relation to COVID-19 and people that have been locked down, and they may not understand that they are suffering from mild or initial mental health issues. And there's lack of awareness of, what the symptoms are, where they go for support. So we're going to be doing a large piece of work around raising awareness and hopefully getting a listening into action group which is service user led as opposed to being driven by service organisations. So that's at early stages. The other one that our board has prioritised is domiciliary care. Now that one is at early stages, and we've had a briefing to the Health Watch Leicester and Leicester manager, and we're awaiting for that to be devolved down to the staff team. And also, as I understand it, this is one where it becomes even more difficult because people who are based within their own homes, it's going to be even more more difficult to connect with them. So if anybody's got any views on how we engage with those, maybe through service contracts and social media, Facebook and other elements, that's one that we will be looking into. And then we're continuing to look at the impact of COVID-19. Now, one of the things that we've been quite successful with is that when I took up my post as deputy manager, one of the conversations was about ethnic minorities not being able to either understand or not being sent information about the pandemic. Now, this might have been an issue that related to marketing communications. Was it an issue about languages? Was it an issue about having a database of contacts so that the distribution of material was reaching the right people? So Health Watch Leicester and Leicestershire, working with voluntary and community organisations, developed an initiative called BME Connect. And most of you may be aware that BME stands for Black and Minority Ethnic. So what we developed was this concept that maybe we need to look beyond translations, and there are many communities in fifth or sixth generations that don't read or write their own languages, and therefore we suggested, why don't we look at things like vox pops, video recorded messages, and especially if those messages have presenters that are BME presenters, GPs and nurses and so on. That has been taken on board by local health services and the CCG, and to my understanding has been extremely successful. I think we're talking of in the region of between 4,000 and 6,000 positive responses. And having walked the job in various areas, I've seen a big difference in terms of what we call connectivity and impact. So people are now from BME communities are wearing masks. To a certain extent, they're wearing a mask when they're on their own, walking on the other side of the street. So, but the precaution is good. Obviously, with the Leicestershire county-wide demographics, it's not going to be as dense from a BME population as a city. However, there are many people that do live in the county, but it would be fragmented rather than specific wards and areas. We are looking at not just BME, but the whole population, of how we will engage with various partners to look at community-owned libraries and having some sort of connection with communities there, looking at some sort of joint collaboration or partnership work with market towns, district borough councils, local authorities and health services. And we had discussions earlier on in this meeting about new planning for estates. So how do we get some sort of more formal arrangement as opposed to some sort one-off contact and negotiation? So any views on that would be really useful. The big issue that I'm quite keen on is around disability. And we know that, although the Disability Discrimination Act has been around since 1995 and now transposed into the Equality Act, disabled people are still not being involved in consultation, in involvement. In terms of communications, the health sector has something called the Accessible Information Standard, which isn't often implemented. So one of my staff has been talking to disabled organisations to be able to develop a similar approach to the BME Connect initiative, to say, okay, let's have a listening into action initiative where we listen to disabled individuals and groups and say, okay, what are the issues for you? How do you contact a GP surgery within COVID-19 if you have a hearing impairment or a visual impairment, and there's a telephone number and it says dial 111 or dial your GP surgery? It's going to be difficult. So there's a specific piece of work that we're looking at there. Other than that, we have 17 community groups and support services that have taken part in a disability event that was organised at Clarence House, the Age UK building. And some of the organisations that had market stands were the Alzheimer's Society, Carers Centre, Fibro Friends, Macmillan and Loros. What was interesting from the feedback from members of the public was that they were unaware of some of those charities and organisations. So clearly, I think there's a need for more awareness raising. There are people now that don't understand what is the difference between 111, walk-in centres. There's a new 119 number, which is supposed to be COVID specific, that not many people have heard about. So there's a real need to review marketing communications, and I'm not aware if there is a coordinated strategy or some sort of marketing communications network where we might be able to work together to address those things. So to finish off, I'll just highlight again some of the areas of work. So BME Connect, working in the area of health inequalities, marginalised groups. We're working with disabled communities. We've got a focus on mental health, domiciliary care. The next 2 quarters certainly will be a drive across the county now that one of my staff members is back from maternity leave. We are doing some development work with our volunteers to say, how do we keep you involved in terms of remote working? Because clearly we can't do enter and view visits due to COVID-19. And then finally, we're doing some work around safeguarding and some work with veterans. And I think that latter one is really important and perhaps relates to the initial presentation about the joint Ministry of Defence and NHS Centre, was it Stanford Hall, so we're quite keen to support veterans and some of the mental health issues or other issues that they experience. So I shall stop there and see if any of you have any questions. I think you're on mute, Chair. Chair, yeah, are you on mute?
Dr. Felton. I'll send him a message.
That's right. He knows. He knows. He knows. He's desperately trying to press the button. Right. Button pressed. Thanks, Prakash. Yes, I think you're right. I mean, I attended a workshop a year or so ago at County Hall on hidden disabilities. Opened my eyes, no end. And I'm now very much involved with autism around my area. Yeah, it's absolutely. I mean, I was mind blown. Actually, I just had no idea. Had not come. Hadn't crossed my path. And that's going to be the same for everybody else. I think I've got Rosita.
Hang on. I'm here. Thank you very much. Couple of general points, if I may, please. Sure. First of all, I think your presentation was extremely informative, but it didn't quite come across in the report all of these wonderful work you have been doing. Maybe it's worth considering a page with just listing all of those achievements. Secondly, I was very, very interested in learning about that you recognise that people can't get to the GP. I have spent constantly getting older people, age concerned, contacting me. And one of the issues is also that a lot of the people can't access the websites to register and whatever else. So therefore, IT is truly wonderful, but how do you get to people? And that brings me to your marketing point. If you're talking about marketing, it's all very well, but how do you reach the people? You know, you're going to have to go back to basics by sending out stickers, leaflets, and going to maybe older people forums and whatever else, because otherwise we cannot reach the people we really need to reach. You've mentioned a list of your forthcoming priorities. And one of the things there's a lot of focus of inner city and people who do not speak the language and whatever else. But there is such a thing of rural isolation to get out there, because you cannot get into the rural areas. And there, besides the people who live there, but there are also BME people living out there, which are far more isolated and without a network than there are in the inner cities. Because I know of quite a few, because they are so oddly displaced, you know. As far as people with disabilities, the county council has got a very good forum and a very good network, and I see Kevin nodding, because I used to be part of it, and it is really, really quite effective. I'm pleased to know that you are creating and looking at a COVID help and support group, because I'm sure that is, and I have mentioned it before, something very, very valuable for people to pick into, but not just while they're ill, but after, to share experiences and whatever else. And now I finish off with my big moan, because all of that was very positive. On page 71, you have got a great big notice from the Leicester City Deputy Mayor. And personally, as Health Watch is quite heftily funded by Leicestershire County Council, I think in order to address fairness, there should be equal page space given between the county council and the city council. And with that, keep up the good work, and thank you very much.
Thank you very much for that feedback, and I will certainly take on board a very valid comment about having the county council support and representation, and I shall feed that back to our board. Thank you.
Thanks, Mukesh. Ted.
Mukesh, thank you very much for your detailed report. And the Health Watch annual report is always presented in a very presentable, colourful but clear, fonted way, without too much writing, and the bullet points are simple and clear, and they aren't long. They usually have 3 or 4 points, and paragraphs again in blocks of 3. It's very good communication practice, especially for something as universal as healthcare. And of course, the people that we really want to help are the people on the more excuse me, the lower end of the socio-economic and educational spectrums, you know, that will find real life examples of things and make this accessible. So there's 2 points. The first one is, and this is going to seem as if it's a criticism, But on page 65, you've got the, or on this, it's 17 actually, Nikesh. You've got the pie chart of here are some of the areas that people asked about. So the headline figure is that this year we helped 351 people. Now, when I look at photographs such as this on page 18, or the Summer Road Show at page 19, it would look that you were engaging with a lot of people. So the question would be, if I was playing advocate, how come only 351 people out in the whole of Leicestershire contacted you? And that is meant in a way to help you broaden your reach. It is going to look as if I'm making a criticism.
No, that's fine.
Yeah, what I'm wanting to do is to assist in your outreach, as I say, because especially the demographic that would need help like this more. And the second point is the my rather favourite subject, which is mental health. Now, people with serious mental health problems will peak and trough all times of the year, more times than others, periods of stress. You throw in a lockdown and it is quite acute, the pressure you put people with severe mental health problems under. So I applaud that you're wanting to make mental health more applicable to the whole population, but I would urge you, amongst anything, that your primary site has always got to be the people with serious mental health problems, from people like, for example, my area covers Loughborough South, and I've got Loughborough Town Centre in my area, and I have seen, I watch on a daily basis the degradation of people's health, but some of the people that had mental health problems anyway. And I think that before you dilute your resources to get a more general message about mental health, these are your core audience that you've absolutely got to put at the top. So what I would want from Health Watch is some reassurance that these people are protected, because to talk about isolation, these people were we were only just beginning to see the effects now with the amount, and I know we did touch on this, where the amounts of crises that are happening.
Thank you. So on that latter point, absolutely agree with you that the focus is on the, for want of a better word, mental health agenda, as it was. All we're doing is we're taking into account the impact of COVID-19 also in terms of the longer it drags on, there will be people that will go into depression. We know that back in the days of the Wall Street crash, people lost businesses and were jumping off skyscrapers, and we don't know what the impact will be the longer COVID-19 drags on. So that was the only sort of reason for branching that out. But the primary focus is on the traditional aspects. Going back to the format of the report and the data, in terms of the quantitative data, I think you're absolutely right. I took a post in March as deputy manager, so some of this work goes beyond March, and I think that some of the information may be a combination of Health Watch Leicester and Leicestershire, as well as Health Watch England, in terms of the work that we do. So I shall definitely feed that back for clarity, and also some of the earlier points made about highlighting some of the more latter work that's been done, and putting that onto maybe an addendum to the report.
Thanks, Mukesh. Very useful. And finally, I've got Amanda.
I haven't got my hand up, Kevin. Sorry.
Whose hand's that then?
Apologies. It was up. I didn't click it. Apologies. I don't have a question. Thank you.
I have discovered a new power today. If I want to actually go and make people's hands go down. Found a new power. It must be something new. Never seen it before. Well, thank you very much, Mukesh. Hopefully you've got some points there that will be useful. We do enjoy very much having Healthwatch come and be with us, and obviously reading our annual report as well. So all the best, and I'm sure we'll see you, if not you and Michael, in the future. Thank you very much.
Thank you. And just finally, just to say that if there are any areas that you feel we could be more effective in as a Healthwatch Leicester and Leicestershire, we are absolutely willing to listen and get involved.
Yeah, thanks very much, Mukesh. I'm sure we will.
Thank you.
So I'm coming to the close nearly. Next meeting of this committee is scheduled to take place on Wednesday, the 11th of November at 2 o'clock. But also for those of you that on the joint health, some of us, the first meeting of several will be on the 23rd of September, but that one starts at 10 o'clock. You'll be getting all the instructions and everything else, of course, and the papers, but just to let you know. I've got no other items that have been asked to discuss because they're urgent. So I think on that, thank you very much for attending, and have a good night. Go and hear what Boris has been up to, and we'll see you soon. Thanks very much.
Thank you very much, everybody.
Thank you, everybody.
Thank you.
Cheers. Thank you. Good afternoon.
Bye, everybody.
Bye-bye.